I will take the first lecture, which is I'm going to share my screen, and hope you can see. Okay,
Yes, sir. We
can you
can.
see my screen
Yes,
now?
we can, sir. Yeah.
Yeah.
We are ready
Okay.
to go. Yes.
Okay, fine. So I will now move on to the first lecture on the anomalies section. So we have divided this into according to the view-based discussions. So I am going to cover the left heart anomalies and a practical approach. So let us see what all we are going to see in this lecture. So we have obviously the most common and a very easily picked up anomaly of hypoplastic left heart syndrome. And I'm going to discuss a couple of variants of this anomaly. Then we have the critical aortic stenosis, and where there is a different more way we can manage this. I'll briefly cover that management aspects also. Then there is this very common, rather common entity called asymmetry of left heart structures, what people call left ventricular asymmetry or left ventricular disproportion. And this is a little bit of a gray zone because many people sometimes label this as hypoplastic left heart syndrome as well. So we are going to try to differentiate these two entities because it's very important. And then there are a couple of rare conditions, which I will show a picture of the diverticulum. And then there is this new thing which is being described, the redundant foramen ovale flap and why it is important. So we had a recent case, and I'll just show that. So first, let us start from hypoplastic left heart syndrome. Now, this is a pretty common abnormality in the fetal series. Postnatally, many a time we don't see this because the diagnosis may not be made while the baby is still alive, because as we see, it's a drug-dependent condition, and many babies actually die before a diagnosis in the postnatal life. But in prenatal, it's pretty easy because it presents with an obvious abnormality of the four-chamber view. Now, this is what is the critical point, the differentiation between a frank ventricular hyperplasia to varying degrees of ventricular asymmetry. So this we will be discussing in some detail about this. Now, the key feature in hypoplastic left heart syndrome is that the apex of the heart will be formed by the right ventricle. So let us see some images. So this is a 20-week primary gravida who was referred because of the abnormal four-chamber view. And here you can see, I have marked the LV and the RV here. And you can see that the left ventricle is a relatively small chamber here. And the right ventricle is clearly forming the apex of the heart. And if you look at the contractility also, the right ventricle is squeezing rather well, while the LV is hypocontracting. Now I put the color on, and what do you see? You see that there is absolutely no inflow whatsoever into the left ventricle. The entire left atrial blood goes across and goes to the right ventricle. So there is no filling of the LV at all. So these images can be actually quite nicely appreciated using the stick technology. This is what's called a surface rendering mode. Again, the small LV cavity, you can see how the walls are not contracting at all. The apex of the heart is formed by the right ventricle. The mitral valve is not opening at all here. You see it's completely shut. And while the tricuspid valve is, you can see it nicely opening and closing. The foramen ovale is open. And if you see the flap is facing towards the RA. And when you look at the color flow, there is absolutely no filling of the LV. The whole blood goes to the right, across the foramen ovale into the right atrium and then to the right ventricle. So the most important features of hypoplastic left heart syndrome in the four-chamber view is, number one, the apex of the heart is formed by the right ventricle. The LV is typically a very small cavity which is not forming the apex. The walls of the LV do not contract as well, and sometimes you may see that the walls of the left ventricle are hyperechoic as well. The mitral valve typically does not open. And when you switch the color flow on, there will be no filling of the LV, no flow across the mitral valve, and the entire blood from the left atrium goes across to the right atrium through the foramen ovale. That is what is called a left to right shunt across the foramen ovale. That is a very, very typical feature of hypoplastic left heart syndrome. Then when we move towards the outflow tracts, and this is what we showed, and remember the normal three-vessel tracheal view, which both Dr. Alpana, Mark, and I, all three of us showed that. Now here, look at the three-vessel view. You see the PA and the aorta, and there's a small SVC also. Two things you can notice about this three-vessel view. One is that there is a reverse flow, a red flow into the aorta. So that suggests that there is absolutely complete obstruction at the level of the aortic valve. So the blood is going into the pulmonary artery, and then retrogradely the blood is flowing into the aorta through the ductus arteriosus. So that is the most striking feature. And secondly, if you compare the sizes of the PA and aorta, you can see that the aorta is much smaller than the PA. So these are two important things. So in the sagittal view also, you can see that reverse flow into the aortic arch very nicely here, suggesting that there is complete obstruction of the aortic valve, what we call aortic atresia. So this is the classical hypoplastic left heart syndrome. Now let us see a variant form. So here also you see the four-chamber view is abnormal. You see the left ventricle here is absolutely very, very thick and so much of muscle in the muscle around, and you see very small LV cavity. And look at where the apex is mostly formed by the right ventricle. But instead, I want your attention on the foramen ovale here. Look at this atrial septum. It is bulging towards the right atrium. You can see that quite nicely. So this is a variant of hypoplastic left heart syndrome with restrictive foramen ovale or restrictive ASD. And then when you look at the pulmonary veins, you see it's quite dilated. You see the pulmonary veins are almost like pulmonary arteries. Normally you struggle to image the pulmonary veins because they are very slender structures. But in hypoplastic left heart syndrome with a restrictive foramen ovale, the pulmonary veins become very big. So let us discuss a little bit of hemodynamics here. So normally what happens? So this is hypoplastic left heart syndrome. So this is the left atrium. And here you find a completely unrestrictive ASD. So the entire left atrium gets decompressed and the blood can freely flow from the LA to the RA and then to the RV. Now, if you put a pulmonary vein Doppler here, you find that normal pulmonary vein pattern, which is what you see here. You find two waves on positive S and the D waves, and then a small reverse wave here, which is called the AR wave due to the atrial systole. But now, so that is what is a normal pulmonary vein Doppler. Now let us look at hypoplastic left heart syndrome with restrictive foramen ovale. So what happens is that when the foramen ovale is restrictive, blood cannot exit from LA to RA. We also know that the blood cannot flow from the LA to the LV because the mitral valve is atretic. So where does the blood go? It cannot go anywhere. So it will just dam up inside the left atrium, increasing the pressure of the left atrium. So that back pressure on the pulmonary veins make it very prominent. That's what we see here. And then when you put a Doppler onto the pulmonary veins, you see this very prominent reverse wave, A wave. So this is an example of a hypoplastic left heart syndrome with a restrictive foramen ovale, while this is HLHS or even a normal heart with an unrestricted foramen ovale. So this is a very, very important assessment in HLHS. Many a time when you make a diagnosis of hypoplastic left heart syndrome, you drop it, okay, fine, nothing needs to be done. This is very bad. And you just close your bags and go home and just say to the family that, okay, fine, there is nothing more we need to do, terminate the pregnancy. But suppose if there is a case where there is a more interest from the family, they are asking more questions, how do you prognosticate this further? This is very important because between a hypoplastic left heart syndrome with a normal good size ASD and a hypoplastic left heart syndrome with a significantly restrictive foramen ovale, the latter, that is the one with the restrictive foramen ovale, has a far worse prognosis compared to the first one. So this is a very, very important thing which you should always look in HLHS. So that is not much about hypoplastic left heart syndrome, which I am sure that most of you will easily pick it up. So today you learned this additional point about pulmonary vein Doppler in this setting. Now let us look at critical aortic stenosis. Now this is usually the more common as a valvar type, typically associated with the dilated left ventricle with LV dysfunction and endocardial fibroelastosis. And now the most important point about aortic stenosis is that this, if it happens early in pregnancy, it can actually progress in utero towards HLHS. So this is something which I'm going to show some pictures also about this in utero progression thing. So this is the four-chamber view. Now, in the first glance, many people may just label this as a LV dysfunction or a cardiomyopathy. That's many a case of aortic stenosis may be just labeled like that. Here you see the ventricles are marked. The RV is normal, but you look at the LV, which is quite large and globular. And if you look carefully on the septal surface, you can see that the walls are quite hyperechoic, suggesting endocardial fibroelastosis. And this is another picture here. You see that the LV is dilated, but in this particular case, compared to this one, the walls are thicker and looks good. And there's some rim of pericardial effusion also. Now let us look at the left ventricular outflow tract. You see here, this is the LVOT, and the aorta looks quite small. And look at the aortic valve. The aortic valve is much thicker, quite thick, and the movement is also significantly reduced. And when you put color Doppler, you see that there is a turbulent flow across the aortic valve. You can see that. And again, the next pictures, you see the thickened aortic valve with a clearly turbulent flow across the LVOT. So this is an example of a predominantly valvar aortic stenosis. It is also important to look at the mitral valve size here, and because there are some new forms of treatment which are now coming up for this entity. So measure the mitral valve size and look at the Z score also, and make sure that the mitral valve is good sized. Now this is another example of critical aortic stenosis. Now you see here, this is the left ventricle, and what I described before, the hyperechogenicity of the ventricular septum. You can see that quite nicely here. The ventricular septum is quite hyperechoic because of endocardial fibroelastosis. But look at the left atrium here. It's enormously enlarged. And look at the pulmonary veins, so prominent here. And the atrial septum is also significantly bulging towards the right side. And that is because in this particular case, there is severe LV dysfunction, and here you see a lot of mitral regurgitation as well. So this fetus is likely to have a pretty severe outcome unless something is not done in time. So, and this was about sometime mid-20-week gestation fetus. So this is an example of critical aortic stenosis with LV dysfunction and mitral regurgitation. And there are a lot of things which you measure in this. And whenever you measure the mitral, we have mitral regurgitation, you can measure the mitral regurgitation jet velocity, which will give you the left ventricular systolic pressure. You can measure the gradients across the aortic valve. And these are some of the things you should always get these numbers, because I'm coming to something later that is case selection for in utero intervention. That's why these things are taken. Now, this is a very nice example of 4D rendering, and I want your attention on this picture where I'm actually showing here. See, the free wall of the right ventricle is contracting very, very nicely here, while you see here the LV is quite globular, and we can see that the walls are practically immobile, not at all moving. So it's like very classical example of severe LV dysfunction. So many a time, unless the aortic valve is properly evaluated, people will label this as cardiomyopathy affecting the left ventricle. Now, why did I talk about the in utero progression and possibility of intervention? So this is the natural history of critical aortic stenosis. So whenever there is a critical aortic stenosis, there is an increased resistance to the LV outflow. This will lead to LV dysfunction. And because of the LV dysfunction, there will be reduced forward flow, and hence there will be reduced growth of the LV. And gradually this will go on as a vicious cycle. And as time moves on from early 20 weeks towards mid 20, late 20, 30 weeks, the left ventricle will start to shrink. That the key thing is the reduced forward flow. And that will result in this whole vicious cycle of hemodynamic changes, perpetuating a simple aortic stenosis into a much more sinister entity. So I'm going to show this. This has been actually described from very early times, 1997 and 1995 by Liza Hornberger in 1995, and Simpson and Charlin in 97, the natural history of AS. So what begins as aortic stenosis may actually evolve into an aortic atresia and eventually a hypoplastic left heart syndrome. So that is the natural history of the aortic stenosis if left uncorrected. So typically, if you detect aortic stenosis very early, before 14 weeks, hypoplasia is universal. Between 20 to 28 weeks, that is where you have a sort of a gray zone. We can progress or remain sane. Typically, aortic stenosis, which is detected late in pregnancy, will have a reasonably good size LV at the time of birth. So it's extremely important to identify the 20 to 30 week spectra, because this is where the progression can actually happen. And I have taken these pictures from Professor Gerald Tulsa from Linz, Austria. He has, this is one of the largest groups in the world performing in utero intervention besides Boston in US. So here, Gerald has actually kindly allowed me to show these pictures in various forums. And this is aortic stenosis LV at 22 weeks. And see, at 27 weeks, you see that this is a typical picture of the dilated left ventricle. And there is even a little bit of mitral regurgitation here. And if it is not treated, this is typically what happens. You see the LV has become very small, and here it is quite significantly hypoplastic. So this is what is important to understand in aortic stenosis. So this is one of those lesions which has this unique thing of in utero progression towards a more severe end of the spectrum, that is hypoplastic left heart syndrome. And that's why the two groups from Boston and from Austria have spent a lot of time and energy studying the impact of in utero intervention, which I'll come to a little later. So there are a large amount of criteria to identify this. And one of the couple of things which are important is that you put the Doppler across a mitral valve. Normally you see two waveforms, the E and the A waveforms, but in this severe LV dysfunction with AS evolving into HLHS, you may see a single waveform. So in this picture, you can actually see that the two waveforms are together summated and what we call a monomorphic mitral valve inflow. And then you see the reverse flow into the ascending aorta, suggesting critical obstruction to the aortic outflow. And the third criteria is a complete left to right shunt across the foramen ovale. So this was a case of aortic stenosis. I will show these pictures later to show the impact of in utero intervention. This is one case which we did, the only case which we did. And here you see that there is no filling of the left ventricle. You can see nicely the reverse, the flow across the foramen ovale, the left to right flow across the foramen ovale. So these are the three criteria based on which people select cases for in utero interventions. Now I would like your attention on the third group of conditions, which is left ventricular asymmetry or disproportion. Now here you see very clearly that the LV looks smaller compared to the RV, but the apex, it is reaching almost till the apex. And now when I put the color on, you see that there is a pretty decent LV inflow as well here. So the outflow tract, so this is the very good four-chamber view. You can see the significant difference in the size between the RV and the LV, but the LV is reaching almost till the apex. Here the left ventricular outflow tract is seen, which appears quite narrow, and possibly there is some aortic stenosis as well. And when we look at the mitral valve here, the mitral valve also looks a bit abnormal. Here you can see that there's a lot of crowding of the mitral valve apparatus, and you look carefully, you can see that the valve is even doming a little bit. So it seems that in this particular case, there is a lot of things which are not normal, but not quite abnormal as well. The LV seems small, the LVOT looks small, the mitral valve doesn't look very good. And when we move further towards a three-vessel view, the aorta is also small. And finally, the aortic arch, there is a clear shelf, which you can see here. You can see here. So what did we find here? There is mitral valve abnormality, a smallish LV, small LVOT, coarctation, and this group of conditions together is what we call Schoen's complex. It's a word. It's a phrase which the cardiologists use. The Schoen's complex typically has a small left ventricle, asymmetric ventricles, but look at the Z-score here. The LV Z-score is minus 0.4, which is almost normal. Dr. Alpana said the median is 0. So minus 0.4 is just a little bit small. The mitral valve also is minus 1.2. Ascending aorta is nearly normal. The aortic valve looks small, but the aortic isthmus is quite small. When we talk about Z-scores, minus 2 to plus 2 is the normal range. And anything which is smaller than minus 2, which is minus 3 or minus 4, is quite clearly small. So here, everything looks small except the isthmus, which is really small. So there is this entity of multiple left heart anomalies happening together, and that is called the Schoen's complex. And this case is an example of that. Now, the final example in this series is this, again, looks like a ventricular asymmetry. You can see that the LV is smaller, but clearly reaching up to the apex. There is the patent mitral valve inflow in this picture. the Z scores were actually, the mitral valve looked small, but the LV was actually reasonably okay. Length was within the normal range. The aorta also was small, minus 1.9, but it was small but not very small. But the aortic arch was sort of normal. There is no coarctation. So this was a case where overall the left heart appeared small, but not to the range of hypoplastic ventricles or severe obstruction or coarctation, etc. So, what is this difference between HLHS and ventricular disproportion or asymmetry? The first thing which we need to look is the cardiac apex. So, here I am showing one picture where you can see that the left ventricle is small, but it is almost reaching till the apex. And this is the other heart where you see the left ventricle is really small and the apex is formed by the right ventricle. So here the LV is forming the apex, while here the LV is clearly stopping short of the apex. So this is a the RV is forming the apex in the second case here. So ventricular disproportion, the LV in most cases will continue to form the apex, or sometimes you may have a biventricular apex. While in hypoplastic left heart syndrome, clearly the right ventricle will be the apex forming ventricle. Now, the second differentiating point is on color flow. In HLHS, typically there will be no mitral valve inflow, while in ventricular disproportion, the mitral valve will be typically patent and there will be inflow. So please use these two evaluations to differentiate between ventricular asymmetry and HLHS, and please avoid terming some of these cases of ventricular asymmetry as HLHS. Now, a large number of these cases of ventricular asymmetry typically may not have any significant heart defects at the time of birth. We sometimes think in terms of coarctation. It is important to do a postnatal echo to rule out coarctation, but many patients may not have coarctations. But what in this study, what they have reported is that on follow-up, a few patients may in fact develop lesions like coarctation, mitral stenosis, etc. So what is recommended is whenever there is a prenatal ventricular asymmetry, we should advise a postnatal echo in the newborn period and also follow up this patient. I usually follow them up for at least about a year. And if the first year echo is normal, then you can sort of tell them all is well and you can go back home. Now, we'll wind up with a couple of quick cases. This is a very interesting case. We don't see this very often. So you see all the four chambers are marked. The LV looks small, and you can see a prominent diverticulum from the left ventricle. And in this flow, you can actually see that there is a color flow into the diverticulum as well. So this is the neck of the diverticulum where the arrow is pointing, and you can see that. So this is a very rare abnormality. This can present in various ways with heart failure, sometimes in utero itself. It can sometimes present with arrhythmias, and postnatally, sometimes there could be clotting inside this diverticulum due to stasis. So this is an example of LV diverticulum. The last case is another case of left heart asymmetry, and this is very, very interesting indeed. So this is clearly, you can see that the RV is big, LV is definitely looking small. But I want your attention onto the foramen ovale. See that? There's a prominent PFO flap, foramen ovale flap, which is bulging into the left atrium. When we put the color on, there is a patent inflows here. And the measurements of the mitral valve, the LV length, all were reasonably okay. This is the RV length Z score. The LV length Z score was minus 1.7, which is a little bit small, but not hypoplastic. The pulmonary vein drainage was absolutely normal. And the LVOT, the aorta was a trifle small, minus 1.9. And in the three vessel view, you can see a normal size pulmonary artery, a relatively smallish aorta. And in the three vessel tracheal view, you can see that the isthmus was minus 3.8. And in the 3VT view, you can very clearly see a reverse flow into the aorta. So this looks very ominous, isn't it? It looks like coarctation of aorta written all over the place. However, this is a very, very sort of a generally a benign condition. This is what is newly described by Palladini and his group, that is a redundant foramen ovale flap, and this may be one of the mimics for fetal coarctation. So something which people have described, and then there are many things in this. You can go and read this article for more detail if required, but whenever you have a ventricular asymmetry, particularly the third trimester, please spare some time and look at the foramen ovale flap and see whether there is anything like what I showed you. And if this is the case, most of the time, it may be a very benign condition. But nevertheless, it's very important to do a postnatal assessment for even these cases to make sure that there is no obstruction. A few words about counseling. So the left heart abnormalities, I'm not going to talk about coarctation nor aortic stenosis because these are topics which are going to be discussed tomorrow. But we will talk about hypoplastic left heart syndrome here. And this is what is called a duct-dependent systemic circulation because the flow to the body typically is dependent on the patency of the ductus arteriosus. Fortunately, in utero, the foramen ovale and the ductus arteriosus maintains the systemic blood flow. That's what you see here. There is the first arrow, the black arrow showed the retrograde flow into the aorta, while this is the flow into the body circulation. However, postnatally, it will have, when the ductus arteriosus closes, unless treatment is begun in time, these babies do not survive. When we talk about treatment for hypoplastic left heart syndrome, obviously it's a pretty complex lesion and it needs multiple stage palliative procedures after birth. The surgery which we do in the newborn period is called a Norwood procedure. And this will be followed by two more surgeries, typically somewhere between 3 to 6 months, called a Glenn procedure, and then between 3 to 6 years, which is a Fontan procedure. The second and the third are common pathways for palliating univentricular hearts. The first is the unique for hypoplastic left heart syndrome. Now, when we look at the long-term data of these cases, the overall, they have a pretty guarded prognosis because the hypoplastic left heart syndrome is one of the lesions which has the highest risk of long-term failure of the heart after the Fontan procedure. In addition, they also have significant neurodevelopmental issues also because the fetal brain is exposed to lower blood flow. Now, regarding the aortic stenosis, I have shown the slide in which the feasibility of in utero progression, the possibility of in utero progression was explained. So people have used that as a rationale to consider in utero intervention, which is the role of fetal aortic valve dilatation. Because they hypothesize that if you relieve the obstruction, it may enhance the growth of the cardiac chambers. So this is again a slide which I have borrowed from Professor Gerald Tulsa, and showing how the aortic valve intervention is being done. A needle is puncturing the left ventricular cavity, going inside here. And now what is done is a balloon with a wire combination will go through this needle across the aortic valve. And then they guide the balloon through across the aortic valve. There you can see that the balloon going across the aortic valve, and then it will be inflated. If you just keep watching this picture, you can see that they will be inflating the balloon. That's the inflation being done, and then you can see that there's a good antegrade flow, and you can even see that there's a bit of an aortic regurgitation also, suggesting that the procedure has been accomplished very successfully. So we did one case in our center. This was actually about 5 years back, and this was the LV filling before the procedure. The entire blood was going across the foramen ovale, and after the procedure, there was a significant improvement in the LV filling. So this baby actually continued to have a borderline LV and was born. We ballooned the valve, but the left ventricle continues to be dysfunctional, finally necessitating a complete aortic valve replacement in the postnatal period, which the family refused. So eventually, though we had a successful in utero result and a live baby, but because of the inability to provide continued care, we lost the baby. So what does the International Fetal Cardiac Intervention Registry show? They show that overall biventricular circulation is better with in utero intervention, 42% versus 19% without intervention. But what we need to understand, and this is a much more sort of a subdued paper, looking the European multicentric study. And what is important is that these patients actually require multiple procedures in their life. Whether they are 2 ventricles or 1.5 ventricles or only 1 ventricle, the number of procedures is immense and they go through a lot of challenges. So hence, these kind of procedures can only be done in extremely specialized centers who can actually handle the whole postnatal care and only with extremely motivated families. It's not something which you would want to do every time. So let me summarize this lecture. So left heart lesions are one of the more common types of CHDs detected in fetal heart screening. And you need to differentiate between hyperplastic left heart syndrome and asymmetry. These are very important points, and don't label a simple ventricular asymmetry as HLHS all the time, because the prognosis is completely different. HLHS is a severe and complex lesion both in fetal and newborn period, quite challenging, and Mark can probably talk about their experiences later on. Critical aortic stenosis again is a pretty challenging lesion. In a very specialized unit for a very motivated family, the possibility of in utero intervention exists for this lesion by careful case selection. While the much more common of the whole spectrum is left heart asymmetry, particularly in the third trimester. Many cases may not have any problems, but it's important to do a postnatal evaluation. And in this context, please remember that the redundant foramen ovale, because it may be a masquerader for pseudo coarctation like situations. So thank you very much, and I can take the questions now or later.
So we can take a few questions now, sir. Firstly, I just wanted to ask you about ventricular disproportion you spoke of, and how would you sort of counsel the patient? What is the prognosis?
Yes, I think this is perhaps the most important left heart lesion in my opinion. Now, Sanjeev, the very simple thing which I look at first is the gestational age. Any ventricular disproportion which is happening in early pregnancy, typically before 20 weeks, you should be really worried, because these are the lesions which can have a fair chance of progression, because there is nothing which is contributing to that, from within the hemodynamic perspective, contributing to that in the early, like first trimester or 16 weeks, 18 weeks, etc. On the other hand, if you have a 32, 34 weeks, you do something like a growth scan or something in late pregnancy and find this, then you may not be really worried, because this is quite normal, because we know that in third trimester, the right heart contributes to about 2/3 of the cardiac output. Now I'm going to bring in some additional elements now. I spoke about one irritant, that is the foramen ovale flap, which may masquerade and cause a pseudocoarct. Now you bring in your left SVC, persistent left SVC. That also enhances the volume overload onto the right side. More blood comes towards the right and may create this apparent disproportion. Now the hard signs which you should always respect is that if the aorta is really small, the Z-score less than -2, if the aortic isthmus Z-score is really small, I would say less than -3, if there is a reverse flow into the aorta in the 3VT view and in the sagittal view of the aortic arch, if you clearly see a coarctation shelf, then these are all the danger signs. And these are all the patients which you will warn that there is a more chances of postnatal coarctation. But I want to conclude my comments from one single case example. This is anecdotal. In fact, this happened to be a radiologist baby. It was looked like an absolute coarctation written all over the place. And, everything was there, asymmetry, shelf, everything, reverse flow. They delivered the baby here. The first day, actually, the same prenatal findings were reproduced in the postnatal echo. We were thinking about prostaglandin and even surgery, but some of the seniors, including the few of us, felt we'll wait and do nothing. And what happened was, after a couple of days, what happens is the postnatal circulation is different as Mark has come back. And, you see what happens is the pulmonary blood flow significantly increases after birth. The lungs expand, the LV and the LA and LV gets filled up, more blood gets pushed into the aorta, and this was a normal baby. And a couple of days before, she sent me a picture of this baby on his first birthday, saying that the best thing that happened was no treatment. I did echoes every 6 hours, but she was grateful for that. Okay. And this turned out to be no coarct. So I think I will also caution people that do not scare people, patients with this asymmetry, using very, horrendous terms like hyperplastic. So be careful, be gentle. As Mark said, treat, counsel with compassion, because you may be in for a big surprise.
Another thing.
Go on, sir. Yes. Aortic isthmus at what level? Yes, there are two ways. I think in the coarctation lecture, it will be covered. I measure the aortic isthmus in two views. One is a sagittal view. Of course, you can measure after the origin of the third branch, which is the subclavian artery. It's very difficult sometimes. But in the 3VT view, where you see the two arches joining together as a V, you see the ductus, the end point where the two arches meet. Just above that, we measure the isthmus on the aortic side and the ductus on the pulmonary side. And you can look at Z score and the isthmus duct ratio. I'm not going to take anything away from, I think Mark is going to talk about coarctation tomorrow, isn't it? So then I don't want to steal his thunder, because I'm sure Mark is going to clearly cover this whole thing without any doubts for tomorrow.
Another thing, so we see like how you spoke about the foramen ovale flap.
Yes.
How do we know it's significant? You spoke about. Can you tell us a little more in detail about it? Yeah.
This
is
is
sometimes suddenly in the late second or third trimester. What do we do?
What actually happens is, anything which is happening earlier in pregnancy needs to be treated with caution. The heart it's nothing. There's nothing complex. It's just a pump. There's nothing much, no brains for the heart at all. It's just a simple mechanical thing. But what it needs is flow. It needs flow. In the cardiology parlance, we say flow translates to growth. So anything which arrests or reduces flow can potentially arrest the growth as well. So you have this foramen ovale, nicely chunky fellow bulging into the LA and standing in the way of blood going into the mitral valve or across the mitral valve. Then you put another dilated coronary sinus due to a persistent left SVC. So you have two guys squeezing the LA from either side, and the mitral valve gets crowded. So less flow into the LV. So less blood goes out. This is, if it is happening early, it can potentially act as a nidus for developing a left heart lesion later. So when three things. So if you have a redundant foramen ovale, if you have a dilated coronary sinus due to a persistent left SVC, and early gestation, then I will be concerned. But if the same set of events happen in late gestation, you may not be so worried. So I think the key factor is the gestational age at which you see. Anything which you see early should be followed up. That's the key message.
Okay. Another question from Dr. Rekha. Where in India is in utero cardiac intervention carried out? How many centers are there?
I have no doubts in saying this. It is not me. I'm not the expert in this. The best person to do this is Dr. Nageshwar Rao in Hyderabad. I think he's a very good friend of mine. In fact, for our case also, he helped us. And we had decided that now we'll try to do this in a very selected centers only, because it's something which is pretty intensive and resource intensive. In my knowledge, Nageshwar has done something like 9-10 in utero cases, including aortic and pulmonary valve. One case, they had a really good result with a live baby who just needed a postnatal aortic valve dilatation. But in a lot of other cases, there were challenges. He also faced pretty much similar challenges like what I had in this. It's not so much of a technical thing. A lot of people can do it, but it's the question of predicting how the LV grows. And Mark will know Wayne Twarowski very well, and even Boston are a bit circumspect about the outcomes, because here you're not the biventricular, which they say is not a normal heart. The LV is not really normal. The LV may be still having dysfunction, diastolic dysfunction. There are long-term issues like pulmonary hypertension. So these are all very high-risk cases. And my point is, the center which performs the in utero cardiac intervention should be equipped to do a newborn aortic valve replacement in the postnatal life. And that's not a simple procedure. It's a big deal. So maybe Mark can add a couple of comments, because he works in place where, there are people doing this.
Yeah, you could tell us about your experience, yes.
I'm sorry. Yeah, no, I agree completely, Balu, with what you're saying. And I personally have had, 5 to 10 patients that I've sent for balloon dilation of the aortic valve, and I've sent them all to Boston. And yeah, like you said at the end, Balu, first you do a balloon valve dilation, the heart is not normal afterwards. The one patient I'm following now, who's probably about 7 or 8, he had 2 neonatal balloon valve dilations. And then he's had a Ross, a neonatal Ross, and then he needed a pulmonary valve replacement. He's had ventricular dysfunction and so on and so forth. But he has a 2-ventricle repair, and he's a 2-ventricle long-term outcome. So it looks promising. But yeah, these successful patients who successfully undergo balloon dilation are left with severe aortic stenosis and often ventricular dysfunction that may or may not improve with time. But the other consideration is the selection of who is the best candidate. Of course, there are many babies who are born with severe aortic stenosis. They went through their whole pregnancy, they have severe aortic stenosis, but their LV is fine. And they have the aortic valve repaired, and they did not undergo balloon dilation. So not every fetus with severe aortic stenosis needs dilation. But I think Balu's point is very good. One of his points is about early detection being so key. If you have a severe aortic stenosis that's very early on, it's more likely to have the time to develop, to impact LV growth and function than if you have aortic stenosis that starts out mild to moderate and then slowly progresses. So we have several centers. We have a center here in Los Angeles that does balloon dilation or offers it, and we have another one in San Francisco, and then there's multiple ones in the United States, but I send all mine to where I think they have the biggest experience. So I think that point is also important, that you don't want lots of different centers doing this. There's a lot of financial resources that are needed and expertise that needs to be developed. So it makes sense to keep, and there's not that many patients. So it makes sense to have just a select few centers to do this type of thing. Yeah.
Absolutely. There is one question which quickly I'll say, tell us about mitral atresia. Yes, mitral atresia is one of the components of hypoplastic left heart syndrome for sure. So this is an entity where the mitral valve doesn't open, and hence there is no flow from the left atrium to the left ventricle. You also need to understand that mitral atresia from a purely anatomical perspective can be seen in other lesions as well. Like for example, you can have a univentricular, single ventricle heart with mitral atresia. And the rest of the anatomy may be different, may not be hypoplastic left heart syndrome. So what you need to remember is mitral atresia is not synonymous with hypoplastic left heart syndrome. That is a key thing, okay? But it is a component of HLHS. Then the next question, Balaganesh Karmagaraj. Yes, Balaganesh is my student. He wants Mark, because he obviously has discussed this with me. He wants Mark to share his experience of redundant PFO flap. I think I have to say that Ganesh has actually done some really good work on this. And in fact, he only opened my eyes towards this. So maybe, yes, he wants to have a perspective from you. And maybe after that, we can move on, because the session is getting very interesting.
Yeah, it's a very, very good question. Very nice discussion, but of course, there's no absolute answers. This is an area of controversy. But I agree in terms of the foraminal valley, as Balu had mentioned, it's very aneurysmal and extending over the mitral valve annulus, and probably in some ways impacting flow across the mitral valve annulus, resulting in less flow through the left heart. Those patients are at risk for cohort, but as Balu points out, sometimes these babies look like they have hypoplastic left heart, and then they're born, the foraminal valley is shifted and is squashed across the atrial septum, and lo and behold, they do nothing. So that's one concern, always to keep that in mind, not to be overly pessimistic, and to keep open the possibilities that the LV, the whole left heart, will remodel favorably. In terms of hyperoxygenation, now this is a controversial area too. Abe Rudolph, one of the grandfathers of our field of pediatric radiology, has written some nice articles, editorials of his concern about the impact of maternal hyperoxygenation on cerebral blood flow and development and cognitive outcomes. So I'm a little concerned about we don't use hyperoxygenation. I think it's a new field, new area, but I have some concern about the use of maternal hyperoxygenation on cerebral development and cognitive outcomes. So I don't know. I'm not the right person to ask in terms of dosing and that sort of thing, because we don't do it, but there's a reason we don't do it, and I'm a little concerned about a potential negative impact of a hyperoxygenation. But again, it's a very controversial area. Balu or anyone else have? Dr.
I am also. I think this probably we can discuss privately, not very anecdotal and very sort of. I think very basic, very preliminary information. I think. So some quick comments, and I think we should move on now. Redundant FO is same as aneurysm, almost similar. Interrupted arch we'll cover later. That's tomorrow. Of course, Sanjeev, there is a very strong request for 4D. I think I managed to impress some of them with those pictures. Maybe it can be a subject for
All of
another.
us, actually, all of us.
Yeah. So maybe that will be our next program.
So one more
I
last
think
question. Sorry to interrupt. One last question. Is there a difference in the prognosis of patients with mitral atresia with HLH versus those with aortic stenosis and HLH?
Look, I think I tried to say that mitral atresia is one of the components of hypoplastic left heart syndrome. Okay, usually when you say HLHS, mitral atresia is there. But then mitral atresia can occur with a different kind of the ventricular morphology and particularly outflow tracts. We have seen it. Both Mark and I will agree that there will be cases of mitral atresia with univentricular heart with normal aorta, sometimes even with pulmonary stenosis. So in there, mitral atresia is just an anatomical feature, not a diagnosis by itself. In hypoplastic left heart, you have mitral atresia with aortic atresia, small LV. So that is it's like a syndrome, a group of findings happening together. So you need to differentiate between that. So don't equate all mitral atresia with HLHs. Define HLHs by a set of features which we have described, which is mitral atresia, hypoplastic LV, and aortic atresia or critical aortic stenosis with small aorta, coarctation, everything. Then regarding aortic atresia, aortic stenosis can have a dilated LV also. But then I discussed that there is a possibility of an in utero progression. So one of the things about pediatric cardiology and fetal cardiology is that please don't actually, try to sort of pack two things together. Having a particular finding doesn't mean that the diagnosis has to be that. Always respect that finding and try to see it as a finding, an anatomical feature. The diagnosis depends upon everything, all the findings of the whole heart. I think with this, we should move on to the next lecture because Sanjeev has a very wonderful bunch of delegates all the time, nearing 10 o'clock, but nearly almost 500 still on. Let us see how many last the whole night. So I would now stop. Yes, Mark. Yes.
Just one quick thing, that if you're in a position to choose between having mitral atresia or aortic stenosis, and you definitely would want to have mitral atresia because, as Balu pointed out, the aortic valve and aortic arch may be very well formed. With aortic stenosis and hypoplastic left heart, you're at risk not only for, the ascending aorta might be quite small, which is not always the case with mitral atresia, but also when you have aortic stenosis or aortic atresia with mitral stenosis, the LV can become hypertensive. You can develop coronary artery abnormalities, just like with pulmonary atresia and intact septum. So in general, prefer to have mitral atresia if you have a choice. But even mitral atresia, all cases of mitral atresia will still be single ventricles leading to a Fontan.
Okay, Alpana, Alpana, your screen? Yes, you can share, Alpana. We can get started. Yes.
Yes.
Yes, we can see the screen. You can just.
Okay, so with this, we come to the kind of the next part of the four-chamber anomalies, and that is the right heart anomalies. So any fetal cardiac anomaly there are different parts to it: the diagnostic ultrasound features, the closed differential for it, associated extracardiac anomalies and genetic syndromes, and the prognosis, counseling, neonatal management, which we all know the pediatric cardiologist will be better able to tell us about. So we will be mainly concentrating on the diagnostic ultrasound features, the closed differentials, and of course the associated extracardiac anomalies and the genetic associations. So what is the problem with right heart anomalies? It is a varied spectrum. Tricuspid regurgitation at 11 to 14 weeks is associated with Down syndrome. Mild TR in second and third trimester may be a transient self-limiting finding. There may be severe anomalies like pulmonary atresia, Epstein's, and the best part is the right heart takes the brunt of even the extracardiac anomalies in terms of volume overload. So when we are talking about the fetal right heart anomalies, there are intracardiac structural defects, which can be these different types. And there can be extracardiac defects, or you can say the functional problems. It may be in terms of volume overload because of vein of Galen aneurysm, AV fistulas, the ductal constriction. Of course, the ductus is, you can't say it's an extracardiac structure, but it is a kind of functional problem. So ductal constriction, ductal closure, or hydrops babies. So all these will have some problems in the right heart. So when we are talking of right-sided heart anomalies, the intracardiac structural anomalies, there are at two places things can go wrong. That is at the AV level, that is the tricuspid, and abnormalities at the ventricular-arterial connection. So, babies don't come with the diagnosis. So we should try to analyze the heart and then look at the diagnostic clues, or then learn the theory about it. So this is a routine anomaly scan at 19 weeks. We put the color Doppler in all our cardiac screening also. So what you can see here is that there is a little bit of tricuspid regurgitation. I'm not showing you the black and white picture because the valve excursion was normal. It was not echogenic or dysplastic. And as you can see here, it was around 178, almost nearing to 180 centimeters per second. And the outflow tracks were normal. If you see this particular case this is again at 17 weeks, 4 days. So if you scan here, if you see here carefully, this is the left side, this is the right side. And even at 17 weeks, you can make out that there is a hypertrophy of the right ventricle. You can see that this valve probably appears a little thickened. The excursion is not all that good. And then if you are looking at the color Doppler, you can see that there is a great deal of tricuspid regurgitation. And you can again see that the outflows were normal. The 3-vessel trachea view was normal. And you can see here, this was quite a bit of regurgitation. 265 gradient was almost 27 millimeters. So then when you are thinking of this, what it could be, the outflow track is normal. So it is a tricuspid abnormality. Is it abstinence? Is it tricuspid dysplasia? Is it just a regurgitation? So it is not an abstinence because we've seen that the valve was normal structurally. There was no septal leaflet apical insertion. So it may be a dysplastic valve if the valve itself is structurally abnormal, or it may be just a regurgitation, which we will come to it, the causes of the tricuspid valve regurgitation later. This patient came for the knuckle scan, the 11 to 14 week scan. The NT was normal. And what you can see here, this is the left side of the heart. And if you look at the right side, almost there is no cavity, if you see here. And then if you're trying to look at the outflow tracks, you can see here there is hardly any. It's a very small outflow tract. Again, 11 to 14 weeks, early fetal echo is a topic in itself. I always prefer to do a TVS, transvaginal fetal echo, whenever we see any problems in the transabdominal scanning. Of course, these are the transabdominal images. But this was something like, there was no flow across the tricuspid valve, and there was a reversal, and that could be seen even at 12-week scan very well. So this was almost like a hypoplastic right heart kind of a syndrome. There was no inflow and the outflow was reversal. If you are looking at this heart, this is the left side. When you are analyzing the heart, the 4-chamber view, the situs size axis are all normal. You look at the atria, are they two equal size atria? Well, probably this, right? This is the right atrium, which is slightly smaller. You can see that this foraminoval flap is bulging quite a bit, as we've been discussing about this quite extensively in our previous session. And then, of course, there is a hypertrophied wall of the ventricle. There is a diminutive cavity. This valve is not opening very well. So if you are going to put the color Doppler on, and then you see that there is hardly any inflow. There is a lot of this flow which is seen from the right atrium to the left atrium. And then if you are trying to see these structures, the outflow tracks, you will see that there is the retrograde flow in the pulmonary artery. And then again, this may be a typical case of hypoplastic right heart, again, which is not as common as the hypoplastic left heart, but this is the hypoplastic right heart syndrome. Then with this, we come to a simple, straightforward abnormality. As I said, again, you look at always, whenever you are analyzing heart, you have to focal zoom it, but always keep the spine in picture. That gives you a very good orientation. So this is the left side and this is the right side, where the left sided structures are normal. The mitral valve is opening properly, but as you can see here, this is a thick echogenic structure here, and there is a VSD here. This cavity is diminutive, and all the flow, what is coming inside the right ventricle, why it is getting formed is because of the flow through the VSD. Outflows were normal in this case, because there was a flow in the right ventricle, and that's why there was a flow in the pulmonary arteries. But this is typically a case of tricuspid atresia with VSD. If you see this, a four-chamber view may not really look so abnormal, except that probably the right atrium is more prominent. But if you look at the color Doppler and then you see that there is an abnormal color flow, there is an aliasing, and then if you concentrate on this structure in your grayscale imaging also, you can make out that there is the apical displacement of the septal leaflet. And if you look at the outflow tracks, rich presses is a low ammonia printed rich color or valve is softer or shinier.
Alpana, please hold on, please.
Yeah.
Amit, can you mute everybody, please? Yeah, you can carry on, Alpana, now.
This is the outflow tracks, and as you can see here, this is the SVC aorta, and pulmonary is very narrow, and there was in fact a retrograde filling of the pulmonary arteries. So then now if you see that there is that offsetting, if you look at this valve and where the septal leaflet is seen. So this is typically a case of Epstein's, and it is not just dysplastic valve. Of course, a dysplasia and regurgitation are a part of Epstein's anomaly, but this is typically the Epstein's structure. So let us look at some of the points which we can differentiate the abnormalities. So if you're talking about tricuspid valve abnormalities, we are talking about tricuspid dysplasia, the Epstein's anomaly, the tricuspid atresia, which is almost always with the VSD, and the tricuspid regurgitation. So when we are talking about Epstein's, we know that the septal and posterior leaflet of the tricuspid are displaced inferiorly from the annulus towards the apex, and that's why there is an atrialized portion of the right ventricle. There's a wide spectrum from minor form of it to the most severe structure. But what are the clues to the diagnosis is the cardiomegaly. More than cardiomegaly, it is the enlarged right atrium. There is a septal leaflet apical insertion, which is the most important point to be noted. The color Doppler is important because it will tell you the holosystolic regurgitation, very high peak velocities, and the TR jet is arising not from the tricuspid valve where you think it will be, but it is coming somewhere from the middle of the right ventricle. And that gives you the clue to the diagnosis of the Epstein's. Most cases, isolated associated findings are rare. Poor markers are massive cardiomegaly, pulmonary stenosis, and hydrops. And this is just the prognostication, how you do the ratios. So you have to calculate the area of the right atrium, including the portion of atrialized ventricle, and then the area of the remaining three chambers, and then the ratio is calculated. And then of course the grade 4 is the ratio more than 1.5, and which is very poor with 100% mortality. But overall, the prenatal detection of Epstein's has a poor prognosis. Whereas if you come to a dysplastic valve, again, it is a heterogeneous group. The TV leaflets have normal anatomic insertion at the level of annulus. So this is the point to be noted. It is a thickened valve leaflet, enlarged right atrium. Again, color Doppler is helpful. You sometimes may see a reverse flow. If there is a lot of regurgitation and there is not enough forward flow through the pulmonary, then you will tend to see the reversal, and you can see there is a massive amount of regurgitation here, and it is almost reaching to 346, and the gradient is around 47. So outcome is good except in cases of cardiac failure or a severe cardiomegaly. This is another case of just a tricuspid dysplastic valve. You can see the excursion of the valve is abnormal, and you can see that there is a lot of tricuspid regurgitation. The RA is dilated, RV is little bit dilated, you can say, and there is a lot of regurgitation there. Tricuspid atresia with VSD, relatively simple diagnosis. There is a diminutive RV inlet type of VSD. That's why you always tend to pick it up. This is generally classified into 3 types. One is with the normally related the great arteries. The type 2 will be TGA type of the arrangement, and then there will be a common arterial trunk or LTGA kind of an arrangement. So what are the diagnostic clues? Are the 4-chamber view is diagnostic. The RV is small, VSD is seen. Here this VSD is small. So that how much is the VSD will decide how much of the cavity, how much of the RV cavity you're getting. Myometrial contractility and RV wall are usually normal. AV junction appears echogenic, as you can see here. Thickened tissue, interatrial communication is very large, as we saw here again. This is a very large interatrial communication with the foramen oval flap. And typically what you see is IAS, the interatrial septum and the interventricular septum are usually malaligned. As you can see even here, this is the interventricular septum and the interatrial septum is somewhere here down, and those are, sort of malaligned. They're not in that same line. So this is typically seen in TAVSD. Color Doppler is useful. Ventricular arterial connection should always be evaluated. 80% of the times TAVSD is with normally related great arteries. And let us come to the tricuspid regurgitation. Now it is a hemodynamic event. It is not that the valve has to be echogenic or dysplastic all the time. It is detected on color Doppler or PW. So a precise description and the quantification is very important. The duration, whether it is pan-systolic, mid-systolic, the severity, which is by peak velocities or the gradient across them, and the extent into the right atrium. It may be less than 1/3 distance to the opposite wall. It can be less than 25% area of the right atrium, or almost occupying the entire of the right atrium. So you need to describe these properly. So here it is a mild tricuspid regurgitation. It is not even reaching to the opposite wall. It is not occupying even a 25% area of the right atrium. So these are certain features of what you tend to describe when you are reporting these cases. Trivial TR is an isolated finding. PSVs of less than 180, sometimes if the heart is structurally normal, tend to be normal later on when you see them in the 3rd trimester. So if you see here, this is also a TR, but this is only early systolic. This is a pan-systolic or a hollow systolic TR. Here you can see there is only a little bit of a TR. It is not lasting for the entire length. This is a mid-systolic kind of a TR. So this is how you tend to describe the TR. As you can see here, this is a TR which is extending till the opposite wall. This we already saw. It was coming all the way till the opposite wall. This is a massive TR. It is occupying the entire right atrial area, and it is dilated also. So these are, kind of the different descriptions to the TR depending on its extent into the right atrium. So again, sometimes, you see that everything is structurally normal. And as you can see here, RARV is mildly dilated. You see that the pulmonary artery looks a little bit of a dilated structure. And then if you're trying to see it on the color Doppler, there is a regurgitation. If you are coming to the outflow tracts, you see sometimes, you see that there is, in fact, no forward flow coming to the pulmonary arteries. Now, why is that so? It is because of the ductal constriction or a ductal closure. So there is typically TR, there is PR, There are high velocities across the ductus, and these are again, these causes should be remembered. It is not that it is always because of some structural defect, but it is just a functional problem. And this typically happens in third trimester, especially when you're treating the polyhydramnios with prostaglandin synthetase inhibitors. There may be oligohydramnios, reduced movements, and typically the obstetric Doppler is normal. In fact, we get a lot of patients for reduced movements for Doppler, and then you tend to pick up these findings. So these are generally the features which is seen in the ductal constriction patients. And then those who are interested can go through this Ravi Shavi's book, where he's given a lot of causes for the tricuspid regurgitation, from trivial causes to the ones where it is associated with heart cardiac defects, to the ones with right ventricular outflow obstruction, and then the volume overload and the myocardial contractility like cardiomyopathies and things like that. So we have covered almost all of these intracardiac structural abnormalities at the tricuspid valve level. So we will see some of them at the pulmonary valve or pulmonary arterial level. So if you look at this now, this 4-chamber view looks quite okay, outflow tracks, 3-vessel trachea view. But then, as I said, this was a patient at 20 weeks anomaly scan, and if you put the color Doppler, you immediately see that there is an aliasing here. And then if you are seeing this, the arch view, you can again see that there is an aliasing here. And then you know that this is a pulmonary stenosis, and you can see that the velocity is at 237. Pulmonary stenosis will be, of course, covered in the arch anomalies next tomorrow. But again, it can repercute into the right ventricular hypertrophy. So I've just covered it here. This is a very old case of ours, almost 11 years back. Sorry for the quality of the video maybe, but this is the only one which I had. This is the right heart, which is hypertrophied. This valve probably is not opening very well. And then you want to put the color Doppler on to see what is happening at that level of the valve. So you know that, of course, there is a tricuspid regurgitation. There is hardly any inflow there, and the left ventricular inflow is seen properly. But what catches your eyes is this kind of aliasing here. Sometimes, because of the pericardial fluid and the heart contractility, you tend to see some color aliasing, color flow in the pericardium. But you don't really see so much of aliasing there, as you can see here. And the best way to confirm that is to put the spectrum on. And this is a typical high velocity pattern, to and fro flow, typically seen in the ventriculo-coronary arterial connections. And these are typically known in the pulmonary atresia with intact ventricular septum. So once you see something like this, which are a hallmark for that particular abnormality, you are quite sure of your diagnosis. So then, of course, you want to look at the outflow tracks and then see that there is no communication between the right ventricle and the pulmonary arteries. And again, you can see here that there is a retrograde flow. As you can see here, there is a retrograde flow through the ductus and filling the pulmonary arteries. So this is typically a pulmonary atresia with intact ventricular septum. Now, if you see this, the 4-chamber looks normal. And then when you are coming to the 5-chamber view and the outflow tracks views, you know that there is a subaortic VSD, there is an overriding vessel. And then when you're trying to see about what is the other outflow, then you know that this is very narrow. This is the pulmonary artery which is branching. You should try and find its connection with this one large vessel or with the right ventricle. And then when the color Doppler is put on, you are seeing a sort of kind of an aliasing there. Normally you don't see any vessel here. And then when you are thinking in terms of PAVSD, of course, again, that will be covered extensively with the topics of CAT. But again, it is a right heart problem. So these are the typical MAPCAs, what you are seeing. The pulmonary flow will be through the tortuous ductus arteriosus, but you are seeing those MAPCAs there, and those are typically the major aortopulmonary artery connections. And this is another example of the MAPCA. Again, as Balu said, that there are the other vessels which come in the arch view, that is the pulmonary vein and the artery. So you should always put the pulse Doppler on, check that it is not a vein. You have to trace this vessel where it is going, and then see that this is going towards the lung, and this is actually a MAPCA. This is a different patient. This was at 19 weeks. The previous patient which we saw was around 26 weeks. Now this is again with the high frequency transducer, so it was possible to see these vessels well. So this is pulmonary atresia with VSD, where the hallmark is typically the MAPCAs. Then again, there are some conditions where you're not very sure. The hen first or the egg first kind of an approach. There is a very severe tricuspid regurgitation. There was no Epstein's anomaly, but if you look at the outflow tracts, there was the retrograde flow through the ductus, and there was no communication of the pulmonary seen with the right ventricle. This is again about 10 years back. I was closely associated with one senior pediatric cardiologist whom I used to, always consult to for the opinion. Even she felt that this was pulmonary atresia. The septum was intact, but then we always expect the ventricular cavity to be diminutive. And of course, there is a rare variety of this PIVS where you get dilated chambers, but then again, it will always remain as a debate whether the tricuspid regurgitation was so much that there was no forward flow, or it was actually a PIVS, and that's why there was so much of a regurgitation. One should always try and look for that continuity. Look at the valve which is atretic in PIVS, and that will be more easier to see in a, say, neonatal or a pediatric age group, but of course it is difficult in the fetal life most of the times. So pulmonary stenosis is an obstruction to the RVOT. It is not a 4-chamber abnormality, but it can worsen, and you can have it as this kind of a problem in the 4-chamber. This patient, this is at the 20-week scan, and when she came at 32 weeks, you can see that there is a hypertrophy of the right ventricular wall. There is quite a lot of foraminal flap bulging into the left atrium. The gradient had increased, but this patient had uneventful kind of a postnatal period. Immediately on day 1, the valvuloplasty was done. The child is almost 1 year old and is doing fine. The clue to the diagnosis, of course, the color Doppler is helpful. But again, as we saw in our previous lectures, you should always look at the valves. It should completely disappear in systole. So if that excursion is not really good, you can suspect even on your grayscale imaging that there is a problem. Valve leaflets which are visible throughout the cardiac cycle are always a problem. Color Doppler, pulse Doppler will confirm the diagnosis, and the 3-vessel trachea view will show the turbulent but antegrade flow. That is very important. Then, of course, there are some associations. It may be the part of Epstein's and DTGA, DORV, and things like that, and some genetic syndromic conditions. And a follow-up ultrasound every 2 to 3 weeks to look for progression is very important. With that, we come to the pulmonary atresia with the intact ventricular septum, and we saw that the hallmark is the VCACs, what is ventriculo-coronary artery communications. So what happens here is there is a dissociation. There is no connection of RV to PA with the intact septum. RV cavity is hypoplastic with thickened myocardium, and rarely it can be dilated. And the hallmark is, of course, these communications, which has this to-and flow. It happens in 1/3 cases. TV is always dysplastic and TR is seen. Color Doppler is very useful to know the retrograde flow in the pulmonary arteries and demonstration of the VCACs. So what are these communications? These are the, what happens is the right ventricle is very hypertensive. It is under pressure. So it forces the blood through the intramyocardial sinusoids with consequent fistulous communications with the epicardial right coronary artery branches. They typically have a bidirectional spectral pattern. There is a retrograde flow in systole because the heart contracts and the blood rushes into those communications. It represents a critical condition and poor prognosis. Of course, these VCSEs are seen in not all cases of PIVS, in about 1/3 cases. And that's why, again, like TAVSD, we can say that there are 3 types. Again, it is not possible to distinguish them into the fetal life, but it is not a rule that all cases of PIVS will have VC ventricular-coronary communications. As you can see here, where the ventricular cavity is totally diminutive, here is where you see these communications more frequently. Whereas this is also a pulmonary atresia, but you can see the inlet portion, the trabecular portion, the infundibular portion are seen, they're developed. Whereas here it is hardly a small amount of infundibular, the inlet portion is seen and everything else is hypoplastic. So this is associated with other cardiac abnormalities like TGA, obstruction to the aortic valve, the TV abnormalities, heterotaxy, chromosomal aberrations are rare. There is a poor prognosis in severe TR and when there is a small tricuspid annulus. When we see VCSEs and associated extracardiac anomalies, again, the prognosis is poor. We will just quickly go through these pulmonary atresia with VSD. Again, it is covered extensively with CAT. But again, as I said, there are these 3 different types. When you can see the confluence of pulmonary arteries and a main pulmonary artery, that is type A, and here you will not really see those MAPCAs. When there is a small pulmonary artery, a diminutive pulmonary artery, the confluence which is seen, you may see MAPCAs, and here there is no pulmonary artery, no confluence seen, and then here they are more commonly associated with MAPCAs. They are, initially it was called a severe TOF or CAT type 4, and it is typically characterized by atresia of the pulmonary valve, hypoplasia of the pulmonary tract, membranous or infundibular VSD, and overriding aorta, and MAPCAs are the hallmark of this condition. And to look at the MAPCAs, basically you need to put your Doppler settings at a low velocity scale and a thorough evaluation of the descending aorta. More than 1 MAPCAs will be found, and follow-up examinations can detect MAPCAs. Supposing you see it at 18 to 19 weeks and at first attempt you may not see it, but as the pregnancy advances, you tend to see it. So this is typically not a 4-chamber abnormality, but it is a 5-chamber abnormality with VSD and a retrograde flow in the ductus. But what one should remember is there is a high incidence of chromosomal aberrations, and it is a 10-fold increased risk in infants of diabetic mothers. So we get a lot of patients, the diabetic mothers, for a fetal echo, and this should be kept in mind and should be sought for. Then the hypoplastic right heart is again rare as compared to hypoplastic left heart, but it is underdeveloped right side of the heart, including the right ventricle, the tricuspid valve, the pulmonary valve, and the pulmonary arteries. There is a small right ventricle with hypertrophied wall, small or absent pulmonary artery with decreased or absent flow through the tricuspid valve. Most of the times you hardly see any inflow and outflow. And of course, it can be an evolving anomaly with other structures. The other rare abnormality is the JUL anomaly. I don't have any image. This was taken from the internet, but it is an unusual cardiac disorder which affects the right ventricle, where there is almost complete absence of right ventricular myocardium. There is a tricuspid valve which is normal, and the septal and left ventricular myocardium is normal. And that's why you see it something like an aneurysmal dilatation, which is very rarely reported prenatally. So just to summarize, when we are talking about right heart abnormalities, you need to assess the RA size, RV morphology and size well, the IVS, the interventricular septum and interatrial septum. You have to look at the tricuspid valve, the pulmonary valves and arteries, the ductus arteriosus and the great vessels. And then at each level, you will find some clues. If it is a normal size or large interatrial communication, the right atrium is normal, it is TAVSD. If it is mildly dilated or normal TR, it is PAIVS. If it is a largely dilated right atrium and TR, then it is Epstein's or tricuspid dysplasia. Then you look at the RV cavity. The RV cavity is small, that is HRHS, PIVS or TAVSD, or if you have RV which is large, then it is because of premature ductal constriction or maybe volume overload conditions. Then the RARV is normal in PAVSD, and then the outflows will be abnormal. So then when you start looking at the interventricular septum and the interatrial septum, we saw that there is a large interatrial communication with the redundant foramen ovale. In TAVSD, we saw a few of these examples in HRHS. Normal FOV will be in PIVS or in PAVSDs. And of course, the intact ventricular septum or a bulging will be in PIVS. And if there is a VSD, it is TAVSD or a PAVSD. In TAVSD, the VSD is inlet VSD, and in PAVSD, the VSD is outlet VSD. And then you look at all these valves greatly: a thickened echogenic valve in TAVSD, a dysplastic valve with TR in PIVS, normal in PAVSD. And similarly, you can look at the pulmonary arteries to have these clues about the patent PV in TAVSD, atretic valve with a narrow pulmonary artery in PIVS. And sometimes it is absent or very small, very narrow, difficult to visualize pulmonary artery in PAVSDs. The ductus, you will see antegrade flow always in TAVSD, retrograde flow in narrow in PA with IVS, retrograde flow and tortuous ductus in PAVSDs. And great vessels, of course, we saw that they're concordant in 80% of time in TAVSD, 20% it may be transposed, and so on and so forth. So at each level, you will have clues and you can diagnose these conditions better. There are other characteristic features like VCACs in PIVS and MAPCAs in PAVSD. So as we saw earlier, there are varied causes. You have to look at cardiac and extracardiac problems. TR at 11 to 14 weeks is a marker for aneuploidy, whereas in second and third trimester, it may be physiologic, it may not be pathologic. And a systematic analysis of the atrioventricular connection and a ventricular-arterial connection helps in clinching the diagnosis, and not to forget the extracardiac structural analysis. Of course, you have to always counsel the patients about genetic and chromosomal associations and appropriate invasive testing. And as we've been discussing earlier, counseling at 19 to 20 weeks, it's always challenging and different than counseling towards term when you are following up these patients in terms of delivery. Thank you.
Thank you, Alpana. That was a wonderful walkthrough with the right-sided anomalies. We will wait for any questions from the audience.
Take it a little later. We are late, probably.
I think.
Yeah,
all right, okay, we can go forward, and anybody has any questions can put in the chat box. We'll answer it at the end of Dr. Mark's sessions.
Yeah, so I think Dr. Mark, that may be better because we can probably take this together.
Okay, sir. We'll go ahead that way. So, Dr. Mark, could you please share your screen and we'll go forward with septal abnormalities? Yeah.
Yes, but you'll forgive me. I cannot let this go by without congratulating Dr. Alpana on such a wonderful presentation. She covered so much material. People want to review this in detail because there's so many pearls in there. But just a wonderful job. The mention about TR, how it can be normal, and you need to evaluate the context, the genetic considerations, all these things that you mentioned were wonderful. Such a wonderful presentation. Very good.
Appreciate it.
So let me see. What time is it over there, I wonder?
It's just 10:30, sir, for us.
Just 10:30. You're awake? I hope I don't put you to sleep for this. Okay, so can you see my presentation?
Yes, sir. We can go forward. Thank you.
And it's not too jumpy?
It's perfect, sir. We can go ahead.
Okay, all right. So good. So we're just going to be talking. It's a little bit late, but I'm going to be talking, as I usually, just about the essential aspects of septal defects that everyone, I think, should be aware when you leave today. Not every single nuance, but some of the essential defects. This is about just to take home. So how good are we at prenatal detect? This is one study of many, of course, around the world showing how good or bad we are at prenatal detection of congenital heart. This came out in 2015. This is looking at babies who underwent surgery in the United States under 6 months of age for heart disease. So that's the definition of major heart defect. They needed surgery. And of those, what was the detection rate for septal defects? If you look here, VSD here, the detection rate was 12%. Now, of course, many of these are small muscular VSDs with perspective without color you won't pick up, but many of them were more significant defects like subaortic VSDs, I'm sure, that we really should not be missing. And then AV canal defects I'll be talking about as well. You would think AV canal defects should be much more straightforward, but less than half of those were being detected prenatally in the United States. And of course, parts of the world will have better detection rates, other parts even less good than this. So we want to improve detection rates for ventricular septal defects, in part because of the clinical implication that may have in terms of optimizing outcome, because some of these defects may be related to outflow tract obstruction, but also, as Dr. Alpana mentioned, the potential for genetic associations or extracardiac abnormalities. But I'm going to be trying to talk just about 4-chamber view abnormalities, even though it's the outflow tract VSDs that may be even more important to detect because of the implication for ductal dependent disease. But let's talk about the 4-chamber view. This is the 4-chamber view on the left. This is our Tesser's diagram in my chapter Increasing in Resonance textbook. And here's an analogous 4-chamber view. So we're looking at these portions of the septum. This is the inlet septum, of course, just underneath the AV valves that can be included with AV canal defects. And then all this is muscular septum. So of course, 4-chamber view, we are not seeing the membranous septum. We're not seeing the subaortic or subarterial or subpulmonary septum. We're not seeing the conal trunctal septum. We're just seeing the inflow and the portion of the muscular septum. So muscular VSD is probably the most common. Whenever I make a diagnosis of this, which we do all the time because it's so common, I always emphasize it's the best heart. If you're going to have a heart defect, this is the best one to have first, especially if it's small, because it's most likely not to require any medication or surgery ever, probably likely to close spontaneously at some point in the first few years if it's small, and least likely probably to be associated with genetic abnormalities or other extracardiac abnormalities. So it's the best one to have. Of course, it's very easy to overcall muscular VSD. Sometimes people are referred in for muscular VSD. I see them a month later and there's nothing. And then the thinking is, well, maybe it closed. I think more likely that it was never there. So how do we avoid overcalling muscular VSDs and also avoid missing them? Well, again, we want to talk about optimizing the image. Like here on the left, the image is optimized on the left and the color is optimized, but the angle is not. It's very easy to miss a VSD. This is all the same patient. Believe it or not, it is the same patient. You might get a glimpse of a low color there. Here we turn the baby, or not turn the baby, we move the probe around, as I talked about before, to optimize the angle. Here's my favorite view. You could start to see maybe drop out here, but actually the VSD is down here, and you can see that only with color. So the key is for muscular VSDs to optimize the angle and optimize the image, and then use color on top, because many of these defects are so small, you won't pick it up without the color. And of course, generally speaking, they're very benign, but I do personally mention the small possibility for an associated genetic abnormality. Here's just some more examples. You can see on the left, this is a much larger muscular VSD. The larger it is, of course, the less likely it is to close on its own. And in fact, if there's a large muscular VSD, that many of those do require intervention. Sometimes surgically speaking, we can do them. Sometimes we close them by catheter. And but generally, we don't like to do that right away. We don't need to do that right away. We wait at least several months, if not closer to a year of age, to find the right time to close these defects. Sometimes they're so big, we don't close them. We do a pulmonary artery band and allow them time to get smaller on their own. Here you could see on this baby in the middle, you could see the flow direction is from right ventricle to left ventricle. Which is a little unusual. Now, if you look here over here in the atrial septum, you can see the foraminal valley, as we talked about earlier. Here, it's very deviated, so that it's deviated well into the left atrium, suggesting elevated pressure on this side, and in fact, the right ventricle is shunting into the left ventricle. So a little unusual. Usually the shunting pattern is left to right or bidirectional. To have strictly right to left shunting, a little unusual, although we're still sorting out why in some cases the shunting may be bidirectional, or in rare cases right to left. Is that always abnormal if it's strictly right to left? I'm always concerned if it's strictly right to left, but I must tell you it doesn't always bear out to being something significant after birth. It may be related to ductal constriction or other abnormalities in the right ventricular outflow tract, but you need to think about that if the shunting pattern is a little atypical. Here on the right is more typical bidirectional shunting across the VSD. Very easy to miss these or to overcall, and the key is to optimize. So many patients are referred in for possible VSD. But also, here's another tip, is to remember the apex. This is all the same patient. Believe it or not, this is the same patient. On the left, it looks pretty normal. You just figure, well, it's shadow over on the left. But here in the middle, you're still not seeing it. Now here, on the far right, you can see that there's a VSD towards the apex. Remember not to miss the apex. Sometimes the apex is hard to see. I apologize if you hear our dogs in the background there. No upset. So now another thing to mention is the nomenclature. A lot of people confuse inlet versus outlet versus membranous. Again, the membranous septum you do not see at the four-chamber view. The four-chamber view here is on the left, and here is the left ventricular outflow tract on the right. The four-chamber view, we have the inlet septum. Here's the AV valves and the crux of the heart. This is all inlet septum and muscular septum down here. If it's inlet just underneath the AV valves, it's never going to close on its own. If it's muscular septum, particularly small, particularly far away from the inlet immediately directly underneath the AV valves, then it may close on its own. Here in the outflow septum, which is not part of the four-chamber view, this is the membranous septum. You can see actually there's a very small defect here. I don't know if you can see that. It's underneath the aortic valve. A lot of time you'll see dropout above the aortic valve. People will mistake that for a VSD, and I'll show you an example of that later. That's not a VSD, it's normal dropout. But underneath the valve is the membranous septum. If you've optimized the image, you have the right angle of acquisition, you'll be able to pick up membranous VSDs. So let's talk about membranous VSD. Even though it's not technically part of the four chamber, I just figured I'd include that. Here on the left, there's a small membranous VSD you could see here. On the right, I don't know if you can see this, but this is a baby with Down syndrome. I was doing a fetal echo just because of Down syndrome. And in fact, it looks like you could see continuity of the septum up to the aortic valve. But if you look more closely, you can see that that tissue is sort of floppy. And this is because this is an accessory tricuspid valve tissue that partially closes the VSD. It's a membranous VSD partially occluded by tricuspid valve tissue. And over time, even after birth, that tricuspid valve tissue may actually close the defect. You may never need surgery. But this is a large defect right here. It's large because it's more than half the size of the aortic valve. Actually, looks to me like it's at least about the size of the aortic annulus if you take the whole VSD. So again, the key is optimizing the image and the angle. Now this week, there are some questions about the subaortic VSD. I think this is the best way to see it. You want to optimize the angle, which again is the left ventricular long axis, LV on the bottom. My favorite view with the left ventricular outflow tract here, you could see on the left, there's not, if you should have continuity for the septum up to the ascending aorta, and if you look carefully on the left, you could see a dropout there underneath the aortic valve. And there's crowding underneath the aortic valve. That tissue underneath the aortic valve is conal septum that's deviating posteriorly underneath the aortic valve, causing subaortic stenosis and causing the VSD. And here on the right is another example. You could optimize the image to optimize the chance of picking this up. You could see the VSD, you could see this extra tissue, that's conal tissue, that's deviated posteriorly, causing left ventricular tract, causing that obstruction underneath the aortic valve. As you might expect, this will diminish the flow through the aortic arch. This can be associated with a bicuspid aortic valve or aortic stenosis, which we'll talk about later. It can also be associated with aortic arch obstruction, either coarctation or interrupted aortic arch, with DeGeorge or other genetic syndromes in association. Very important defect to pick up, plus it may have implications on being ductal dependent. So you could see how these outflow tract VSDs may be more important to pick up from a cardiovascular standpoint than the muscular inlet or muscular VSDs. So these are examples of how the subaortic VSD will appear. And there's something else I was going to say, but I don't remember it. So anyway, that's the key. Don't want to miss this. This is the way to optimize the angle. And oh yeah, what happens if the conal septum deviates anteriorly instead of posteriorly? In this case, it's deviating posteriorly, causes a VSD and subaortic stenosis. If it deviates anteriorly, my cursor on the right is giving you a hint. If it deviates anteriorly, it causes subpulmonary obstruction, and this is what we think is the single factor causing tetralogy of Fallot. So let's talk about AV canal defects. This is to talk about septal defects of the 4-chamber view. Tetralogy of Fallot is not that. We'll talk about that on another talk. AV canal defects, of course, because of the association with Down syndrome, primarily. It's important not to miss an AV canal defect. The AV canal defects in general, in their own right, do not require early intervention. So early detection prenatally will probably not improve the cardiovascular outcome for these babies. This is not a ductal dependent lesion, but it can be associated with Down syndrome or other abnormalities, even extracardiac structural abnormalities. And some of these AV canal defects have other abnormalities, cardiac abnormalities, that can make them more complicated and a more serious prognosis. So don't want to miss an AV canal defect. But a lot of them are missed. As I mentioned earlier, in this recent study in the United States, if you were a fetus with an AV canal defect, more likely than not, you would be missed at the time of an anatomic screen. So why is that? Well, part of it is explained by this tomographic ultrasound imaging image, where you can see various planar images in parallel across the heart. And you can see over here in the middle, it looks pretty normal. And down here, it looks pretty normal. The only one that looks abnormal is this one here in the middle. So the key is you need to, the importance of the sweep or multiple 4-chamber. You don't want to just get one 4-chamber view. You can easily make an AV canal defect look normal on a 4-chamber view. The key is to go sweep back and forth, get multiple views of the 4-chamber, multiple angles of acquisition, but also sweeping back and forth from transverse cut to the abdomen and then all the way up, as this TUI shows you. Otherwise, it's possible to miss it. So AV canal defects come in 3 types, more or less. Of course, everything's more complicated than that, but I like to distill it down. We can think of it as complete, transitional, and partial. So I'll talk about each in turn. This is a complete defect. It's a large primum ASD, you can see, large inlet VSD, one big AV valve. In this case, it's relatively balanced, meaning if you, in your mind's eye, you can think, can the surgeon close the VSD, close the ASD, and then make a mitral valve and make a tricuspid valve out of this, or is it so unbalanced that that's not going to be feasible? Transitional is large, has a large primum, but a small restrictive VSD. That's important for, as a cardiologist, we distinguish between a complete and a transitional, because complete canals have a big VSD, so the pulmonary arteries see high pressure, so they develop pulmonary vascular resistance and conceivably could develop Eisenmenders if you wait too long to repair. We generally repair complete canals by 6 months of age. Whereas a transitional canal, by definition, the VSD is restrictive, so the pressure the seen by the pulmonary arteries is low, so we can afford to wait a little bit longer than that. And partial canal has an AV, as a primum ASD, as do the other forms of AV canal, but no VSD. Often there's a cleft in the mitral valve, which is difficult to detect prenatal. It may or may not have regurgitation prenatal. So let's talk about each of these in turn. Complete canal, as I talked about, large primum here, large inlet, in this case, relatively balanced. This is a nice view parallel to look at the AV valves to see if it's balanced, to put color on and to see if there's AV valve regurgitation. But of course, the diagnosis of any canal relies upon this view, but also perpendicular. So here's the question I keep mentioning. Here you can see a short axis view of the AV valves. There's the mitral, the left-sided component, the right-sided component. We can characterize sort of Rastelli types and so on from this view. But the key is it balanced? Can the surgeon get away with closing this? Or is one side relatively small and one side relatively big? And here we could see the same thing. Here it looks like the RV is a little bit bigger than the LV, but probably is going to be okay for 2 ventricle repair. That's why it's so important to assess an AV canal in context with other abnormalities within the heart and outside of the heart in terms of counseling. Is it going to be a straightforward single repair for a complete canal with very good outcomes? Or is it going to be a Fontan because it's unbalanced? Or there are other issues. So it's really important once you detect one heart defect to make sure to get all the nuances and details that you can to provide the best, most accurate counseling. So let's see, partial AV canal. Here on the left is normal. I think I showed you this before. It's a favorite view of mine, something I always want to get on every single fetal echo if I can, to make sure the crux is intact. I never want to miss, I never want to miss an AV canal, so I need to see this view. Here's the lower part of the atrial septum. Here's the upper part of the atrial septum. The foraminal valley is quite big, and that's difficult to say if this foraminal valley is too big or not. But for now, for the purpose of this discussion, I'm focusing on AV canal defects, partial AV canal. In a normal, you see the crux. If you come over here to the right, you do not see the crux. It's absent because there's a primum ASD. The lower part of the atrial septum is deficient. So always want to look, is the lower part of the atrial septum deficient? And to do that, you want to optimize the image. Otherwise, it could be very hard to tell. Optimize the image and optimize the angle of acquisition. So here it's deficient. So this is a primum ASD. And you want to make sure you're at the level of the 4-chamber view. And you know you're at the 4-chamber view because you go back and forth and you make sure you're seeing the tricuspid valve opening and the mitral valve opening in the same plane. See that? Mitral valve is opening. Tricuspid valve is opening. The reason I mentioned that it's important to make sure you're in the plane to see the mitral valve opening and the tricuspid valve, because it's very easy, if you look on the left, to think, well, this is a primum ASD. It's the lower part of the atrial septum, right? But if you look carefully, you see the tricuspid valve opening, but you don't see the mitral valve opening. That's because you're not at the level of the 4-chamber, you're actually inferior to it, and you're seeing a coronary sinus, or it's easier to see this if you have a dilated coronary sinus with an LSVC. But if you're not at the 4-chamber view, you can have a false positive partial AV canal. Here on the right, same thing, but looking at it differently, you can see the coronary sinus as a circle, and then you go a little inferior, and it's going from the 4-chamber view down and back and forth. I think I have a diagram here. I'll show you one more. LSVC to a coronary sinus. You can see on the left, you can see the LSVC to the coronary sinus. And on the right, you can see the RSVC and then the LSVC, bilateral SVCs. So that could give you a dilated coronary sinus. And then if you're not careful and you're inferior to the plane of the 4-chamber, you'll look like a primum ASD, just like here. Here, we're not at the level of the 4-chamber view. We're a little bit below it. The coronary sinus may be dilated, so the mitral, so it looks like a primum ASD, but if you look at the mitral valve, it won't open, right? And then here, if you come up to the 4-chamber view, and lo and behold, you've made the coronary sinus is dilated, but the mitral valve looks normal and opens. So that's the way to differentiate it. So let's see, transitional AV canal. Transitional AV canals are sometimes difficult to detect, because the VSD by definition is small. If you see here on the left, you can see the primum ASD, and you could sort of imagine that there is some AV valve tissue, but maybe there's a small VSD right at the inlet septum. And same thing here on the right, you could see a big primum, but you could sort of see that there is probably some VSD. So it's a small VSD. And again, the reason why we differentiate this from a complete is because in general, these don't require surgery quite as early as a complete, but even a complete canal generally does not undergo surgery right away. If it's a balanced, straightforward canal, we wait several months. And this is another view of a transitional. Here on the left, without color, you could see the AV valve tissue partially occluding the VSD. The primum is actually small in this case. And here's some AV valve regurg. There's a cleft mitral valve. Sometimes the primum ASD is quite big, sometimes it could be quite small. So take-home points for septal defects of the 4-chamber view. 4-chamber view septal defects are still commonly missed and often overcalled because they can be challenging to detect. But so remember the importance of image quality, the angle of acquisition, the use of color Doppler that also, of course, needs to be optimized. And of course, looking at the heartbeat. There are still people or places that do not acquire clips, that just acquire stills. If you need to do that because of your particular practice, at least real time when you're evaluating the heart, make sure to watch the heartbeat in real time. And don't just evaluate the heart from still frames. You want to acquire multiple beating 4-chamber views. Again, particularly for AV canal defects, it's easy to miss, but also muscular VSD is easy to miss if you're not at the right plane. So 4-chamber view will not pick up all muscular VSDs. It will not pick up all AV canals. It's important to go back and forth, do a sweep, optimize the angle, and so on and so forth. The prognosis varies with details of diagnosis. In general, though, muscular VSD is very good prognosis unless they're quite big. Rarely it can be associated with extracardiac abnormalities or genetic syndromes. Inlet VSDs, of course, will not close on their own and can be associated with Down syndrome. It's the outflow tract VSDs, which I was not supposed to talk about, but I couldn't resist a little bit. Those are the ones that are more likely to be related to outflow tract obstruction, arch obstruction, and be ductal dependent. So counseling, though, whenever you pick up any type of septal defect, should be performed by a multidisciplinary team with expertise in all relevant areas. If it's a straightforward small muscular VSD, not so complicated. If it's a bigger VSD or an inlet VSD or an outlet VSD, it can be more complicated, and then there needs to be input from all different disciplines to make sure we optimize the outcome. So that was all I had to say about septal defects. And I wonder if we should, Sanjeev and Balu, if I should keep going now or just pause for any questions or comments.
I think we could keep going, sir, and we could take questions at the end of the session. That would be the right thing, I guess. Yeah.
Okay, but see, I'm very awake. It's only 10:25 in the morning for me.
It's just 11 o'clock for us.
Sanjeev, yeah. Perhaps we can just a couple of questions just for a break for Mark. Okay. One question which is relatively simple, which Mark can try and answer is, subaortic and perimembranous VSD, are they the same?
Right. So let's see. So no, a subaortic and membranous VSD. And I'm way into vernacular. I wrote a paper about this. The vernacular of pediatric that we use in pediatric cardiology often is it's erroneous or ambiguous, and it doesn't help people who are learning, such as yourselves, when we use terminology indiscriminately or the terms are not that. So I think the right term is membranous, not perimembranous, for different reasons. But the membranous septum is a small part of the septum that's not at the level of the 4-chamber view. You see it as you go into left ventricular outflow tract on my favorite view, just beneath the aortic valve. That's the membranous septum, and commonly that extends to portion of the septum outside of the membranous septum. the subaortic means that it's a VSD just underneath the aortic valve. All membranous VSDs are technically subaortic. Often in cardiology, when we say subaortic or subarterial, we mean a little bit higher up, and we mean on peristernal short axis that you see it further towards the pulmonary valve, or the aortic, you don't see it in the same location. It's a little bit closer to the aortic or pulmonary valves, if we call it but really subaortic means anything underneath the aortic, so everything is subaortic for the most part. So it's a little confusing. So it's a good question, but it's our fault that we didn't describe these defects better. But if you're saying, if you say membranous, it means a defect that may close on its own.
Yes.
Whereas if you say subaortic, many people who say subaortic mean it's in a different part of the septum that is not going to close on its own. So it can have important implications. Balu, do you want to say anything?
Yeah, that's perfect. Then there is one question about AV canal. The VSD component is actually inlet. Yes, AV canal VSD is typically the inlet component is mandatory, isn't it? Mark, we will agree on that.
Yes.
Please.
I'm sorry. The question was: does an AV canal have an inlet VSD, or the VSD is always inlet? Is that the question?
VSD component is inlet VSD. That's true. This is the question from Dr. Kiran. He has also asked one more question: is outlet VSD and subaortic VSD the same?
Well, again, people use different terminology, and that's why there's confusion, and it's our fault as a discipline that we're not more clear in our terminology. But outlet, I would say an outlet VSD is nondescript. It just means it's not at the level of the 4-chamber view. It's further towards the outlet. So outlet VSD, membranous VSD is a subset, I would say, of an outlet VSD, as is subaortic VSD. It's a subset of an outlet VSD. If you're not sure, you can call it an outlet VSD, but that means it's not in the plane of the 4-chamber view. But it also means if you say it's an outlet VSD, it's more likely possible not to close, and it's also more likely to be associated possibly with outflow tract obstruction or ductal dependent disease.
I think this is pretty much.
And there's also a question, Balu, if I may, one question about if a fetus has isolated membranous VSD without override, and if screening for aneuploidy is negative, is amnio indicated? So that's a good question. It's a whole discussion of who should get an amnio and how good is the screening that I welcome my colleagues to talk about. But
I would like to do the amnio still.
Okay. Yeah. We also would recommend considering an amnio. These babies, even with an isolated membranous VSD, you're right. If the screening is negative, and if there's no aortic override, it's less likely to have a genetic syndrome than if those things are present, but it still is known to be associated with genetic syndromes in some cases, so you don't want to miss it.
My take would be, if there are no other abnormalities at all, like a normal NT, the screening is normal, no other anomalies, I will give an option, but sometimes many people, like it's a cost factor and invasiveness. So it depends.
They may not opt for it, but you discuss it with the.
We discuss it with the family. I think perhaps we can move on, Mark, because you have a pretty important lecture coming up now. That's the last one slated for today. The corner-truncal anomalies. It's an important set of anomalies, includes a lot of important anomalies. So perhaps we can go to that, and then if there are further questions, we can wind up the discussion after those questions.
Wonderful. Okay. Can people see?
Yes, sir. We can go ahead. Yes.
Okay, great.
Yes.
So, and everyone knows what we're looking at the top here, perhaps. But these are some of the cases we'll be talking about over here. This is, who knows what this is? This is TED absent pulmonary valve, and who knows what this is on the right? This is truncus. This is a classic, and I'll talk to you about why truncus is particularly susceptible to ventricular dysfunction and problems in utero, why TED absent valve is particularly susceptible to hydrops compared to tetralogy, whereas transposition generally behaves very well prenatally. It doesn't cause problems usually until after birth. So conventional wisdom, 4-chamber view. Again, the last talk I gave was septal defects, but I couldn't resist the urge to talk a little bit about outflow tract VSDs or outlet VSDs or subaortic VSDs or membranous VSDs because they're so important, in many ways more important than the 4-chamber ones, muscular VSDs. But it is interesting to just 34 years ago, this is Josh Capel and his colleagues and other people, Greg DeVore, Lindsay Allen and others wrote about, published around the same time, the importance of the 4-chamber view for detecting heart disease. And of course, we know now that the 4-chamber view does not detect a significant percentage of heart disease. And actually, the fact is that among infants with major forms of heart disease, outflow tract lesions are more likely than 4-chamber lesions to require early intervention and thus to benefit from prenatal detection. So why are outflow tract lesions more likely to require early intervention? It's because outflow tract lesions tend to be ductal-dependent lesions and vice versa. Ductal-dependent lesions tend to be outflow tract. Now, if you have, well, what about microatresia? That's a 4-chamber view, but the issue is it's not the microatresia that makes it ductal dependent. It's the implications on the outflow. If you have microatresia and aortic atresia, then the outflow tract will be abnormal. If you have, as Balu was talking about, you have microatresia with double outlet right ventricle, it's not going to be ductal dependent. Outflow tracts are so important to look at. So that's why I'm happy to be talking about these in general during this talk, and I think we'll have other talks tomorrow for you guys, tonight for me. But how good are we? This is global detection rates for major congenital heart disease. This is a great paper, by the way, I found. British Medical Journal came out a couple years ago for international detection rates. And this talk, we're talking about tetralogy, transposition, and truncus arteriosus. And this is looking at different, on the left, you can see different programs around the world. And this is detection rates that each program has for the various lesions. You could see the overall detection rate goes from 13% all the way up to 90%. Most of the world, less than 50% detection rates for most lesions. For tetralogy, yeah, going from 6.5 up to 80, 84, 85, but really those are outliers. Most places, more likely than not, if you're a fetus with tetralogy, you're going to be missed prenatally. And that should not be the case. I'm hoping everyone who's watching now, I don't know how many are watching right now, but will learn certain tips or already do know how to pick up tetralogy so you won't be missing tetralogy in your practice. Transposition, likewise, vast majority of cases of transposition are being missed around the world and should not be missed. And I'll be talking about certain tips for detecting tetralogy and transposition. And same thing for truncus. You would think truncus arteriosus only has one AV valve, one semilunar valve, rather, a truncal valve. There's not an aortic valve and a pulmonary valve, so how do you miss it? And yet, a significant percentage of, not as bad as transposition or tetralogy, but a significant percent are being missed. I'm not going to name some of these countries, but some places it's really low. So it shows that I think outflow tracts are still difficult for people to see. People don't want to miss defects, so I think we're here to help people get better. So again, my favorite view of the left ventricular long axis view, very key. Part of the reason that I love it so much is because it's so key to pick up outflow tract abnormalities. If you get this view consistently, you're not going to be missing significant outflow tract abnormalities. And this is point 2.0. This is not looking for outflow. This is looking mainly at the crux of the heart, make sure the crux is intact, and then the inlet septum and the muscular septum. So we're going to talk first about tetralogy of Fallot. This is two views of tetralogy of Fallot. We'll talk about the different types of tetralogy of Fallot. Tetralogy of Fallot, as you know, is, as I mentioned earlier, it's deviation of the conal septum anteriorly into the right ventricular outflow tract, causing the aortic valve to be pulled over to cause a VSD, aortic override, and the conal septum gets in the way of the right ventricular outflow tract, so you get underdevelopment of the pulmonary valve, underdevelopment of the pulmonary arteries in many cases. That's tetralogy flow. This is, again, parasternal long axis view. You could see beautifully the septum, and you can see the dropout here. It's real dropout because you've optimized the image, you've optimized the angle. It's a real dropout right here. And you can see the aortic valve overriding. Now, you don't know it's tetralogy, but if you see this view, you're not sure what it is, tetralogy is a good guess. You need to look at things to make sure that's what it is. Could be transposition, could be lots of things, but it's probably tetralogy. If this is the aortic valve, you could see it's a big aortic valve, and if you measure it reproducibly and get a Z-score, it's going to be above 2 because it's not normal. And of course, tetralogy is important to detect because of its association also with genetic syndromes. It can be associated with DeGeorge syndrome, can be associated with Down syndrome or other syndromes. So it's very important to pick up tetralogy. Plus, it's an outflow tract lesion that often will be ductal dependent. So this is a baby that you want to know about, so you're not surprised when this baby delivers in a small community hospital in rural part of India or rural part of any country where you don't have the right expertise, and it takes a while to make the diagnosis. So here on the left, this is a diagram of the left ventricular long axis view. You can see on the left, this is a normal left ventricular long axis. You could see there's continuity of the septum onto the ascending aorta. There's no dropout beneath the aortic valve. Whereas here on the right, you could see there is dropout. You could see the aortic valve overriding. Another feature that's a little more subtle is that the aorta comes out straight. It doesn't have the normal angle that in the normal heart will come out, but that's a little bit more subtle. Another view that I find, as a cardiologist, we like this view because we could start looking at some of the anatomy that really can have important implications for prognosis. I also like it because you could actually see the coronal septum deviated anteriorly and rightward and superiorly into the right ventricular outflow tract here, causing the VSD here. You could see, you should know right away it's abnormal because the aortic valve should never be bigger than the pulmonary valve. And here it's much bigger than the pulmonary valve. You could see the pulmonary valve may be a little thickened, but you could see the main pulmonary artery. You could start to see it bifurcating. We don't know if it's bifurcating into the RP and the LPA or the LPA and the ductus, more likely, but we're only seeing a bifurcation. So with tetralogy, the prognosis is very dependent upon the branch pulmonary arteries, their integrity, their size, are they confluent? So that's really very important to look at. It's important to look at the branch pulmonary arteries with tetralogy. And you can see both the right and the left really well. You can sometimes see all the way out, see where the right is bifurcating into the lung. You can get really nice, beautiful images that are reproducible that you can use to Z-score to see how small they are and follow them with time. It's very important to see if there's a main pulmonary artery and whether the pulmonary arteries are confluent. Sometimes with tetralogy, the right pulmonary artery may not come off, may not be confluent with the main and the left, and it may come off the aorta, it may come somewhere else. Very important to identify them. It's also important to see what is the direction of flow in the ductus. Many cases of tetralogy flow are not ductal dependent, and nothing needs to be done for those babies until 6 months of age or 6 months or a year of age, because they're pink. They're so-called pink tetralogy flow with only mild right ventricular outflow tract obstruction. It's important to know, of course, that you could have a baby with tetralogy that's pink at birth that will become cyanotic over the next few months, and that's the natural history of tetralogy. But if you look prenatally and you see retrograde flow in the ductus, that suggests that this is a baby with tetralogy who probably is going to be ductal dependent at birth and probably will not be able to go home without some sort of intervention, either ductal stent or a BT shunt or dilating the right ventricular outflow tract. Some people put stents in the right ventricular outflow tract for different, depending on the size of the baby and where you're located and what type of expertise you have or do not have. Many cases of tetralogy have associated right aortic arch. It's unusual to have a symptomatic vascular ring, but right aortic arch is very common. And again, you can see a right aortic arch. You don't want to miss a right aortic arch. Now that we're doing the 3-vessel view, as Balu talked about, you should be able to see the V. Here on the right, we're not seeing a V, we're seeing a U with the trachea and esophagus sort of echogenic and in the middle. This is one easy way, relatively easy way. Sometimes even a 3-vessel view is not easy. It takes practice. So if you haven't been doing it, just start practicing it. But this is one way to show it's a right arch. And the other way is sagittally, as I showed you before. You go right to left from a sagittal view, and you can see with normally the ductal arch and the aortic arch should be on the same side, the left side of the trachea. With the right arch, you go ductal arch, then trachea, and then aortic arch. So 2 ways to show if it's a right aortic arch. Now, there's another consideration with tetralogy is whether how severe is the pulmonary stenosis. Severe pulmonary stenosis to the point that no flow goes across because of anatomic obstruction is called pulmonary atresia. Pulmonary stenosis is obstruction. Pulmonary atresia is complete obstruction. And pulmonary atresia with tetralogy can have a good prognosis, or it can have a very poor prognosis. If this is on the left, this is a case of with pulmonary atresia where there's no aorta pulmonary collaterals being seen off of the aorta. That's a good prognostic category. Generally speaking, if you have tetralogy of flow with pulmonary atresia and you have no MACDAs, that means the pulmonary arteries are being formed or perfused by the ductus. So you have tetralogy of flow with pulmonary atresia with the ductus with usually good-sized branch pulmonary arteries. On the right, this is a case of TET pulmonary atresia where there's no ductus, the pulmonary arteries are very small, and instead you have multiple aorta pulmonary collaterals coming off. You just lower the nyquist, optimize the image, and these red serpiginous structures are aorta pulmonary collaterals that perfuse the lungs because the pulmonary arteries are so small. In this case, this is a very poor prognostic subset of tetralogy, and a poor subset of tetralogy with pulmonary atresia. You'd rather have tetralogy of pulmonary atresia with ductal-dependent pulmonary blood flow than with MACDA-dependent pulmonary blood flow. And it's nice to have as much information as you can before delivery so you can counsel and then decide where to deliver. So most cases of tetralogy of flow do not develop hydrops prenatally and do not have airway disease after birth. So why, with tetralogy of flow with absent pulmonary valve, are these fetuses at risk for both? Well, the risk for this is tetralogy of flow absent pulmonary valve. We call it absent pulmonary valve. It's not the best term. There is a valve tissue. It's just very redundant, and it causes stenosis and regurgitation. There's usually no ductus, so blood flow goes across the pulmonary valve into the pulmonary arteries, and there's no ductus to escape. So it goes out, starts dilating the pulmonary arteries, and then you have primitive pulmonary valve tissue. So there's pulmonary regurg, which you can see on the right. So pulmonary regurg, and then so you have back and forth flow. The pulmonary arteries get very big. You get hydropic because the right ventricle dilates, the tricuspid valve dilates. You start to get tricuspid regurgitation. That doesn't happen with tetralogy of flow. It does happen with tetralogy of flow with absent pulmonary valve. And the airway disease, as you might already know, is because the pulmonary arteries are so big that they can either cause hypoplasia of the lungs, unusual, but it's possible. More commonly is that the lungs are relatively well formed, but the trachea and the bronchi are compressed by the branch pulmonary arteries. This is another three vessel view of the in a fetus with tetralogy of absent pulmonary valve. You can see here, this is the aorta going to the wrong side or the right side of here's the trachea. It's the right arch. And here you could see very big pulmonary arteries here with flow that's wrapping around. It's very unusual. So the aorta is over here, very big pulmonary arteries on the left. And here you can see why you get these babies are at risk for airway disease. Look at how big these pulmonary arteries are, and you can see the trachea starting to come through. Look here, you can see the trachea being compressed right here. And on the left, you can also see the trachea is being compressed by the branch pulmonary arteries, and that could cause major airway issues after birth, could cause difficulties breathing, could require intubation. Sometimes causes mild airway disease with reactive airway disease. Sometimes there's no airway disease at all. Many patients are born with tetralogy of flow absent pulmonary valve. They do not develop hydrops. They do not develop any airway disease. They do really well after birth, and I follow a few of those myself. So the prognosis is not always terrible. Sometimes people do MRIs to help figure out how big the PAs are, but it's still a tough call to know which babies are going to have respiratory issues after birth and which cases will not. So these are babies that you really want to deliver at a center where you have expertise that can attend to these babies if they are sick when they're born, including ENT to help intubate if that's necessary. It's unusual, but you want to be prepared. Transposition of great arteries is the next area to talk about, and I know we're covering a lot of ground, but hopefully not going too quickly here. So tetralogy, the transposition of great arteries, you can see here, and over here you can see this transposition with the VSD by color. So there's two types of transposition, right? There's detransposition and L-transposition. Detransposition is when you have transposition, all kinds of, the definition of transposition, period, is the aorta off the RV and the PA off the LV. That's all, whenever you say transposition, that's what it means. Aorta off the RV, PA off, aorta off the RV and PA off the LV. So switch, that's transposition. But then there can be two types. Detransposition, you have transposition plus the right atrium the left atrium connected to the left ventricle and the right atrium to the right ventricle. So it's transposition with atrioventricular alignment concordance. That's the way I would look at it. That's what detransposition means. You have transposition plus atrioventricular alignment concordance. It's the most common form of transposition, 10 times more common than L-transposition, which we'll get to. And it's typically not associated with genetic syndromes, typically not associated with extracardiac abnormalities, but is also typically missed. And part of the reason that it's typically missed and so easy to miss is because the best views to detect transposition are not routine. We do not do these views as part of the screen. This one on the left, this is not a screening view. This is sort of an unusual angle. Same thing here. This is sort of almost a sagittal view looking at the arch. You can see the aorta here, the PA and the ductal arch here. These are not routine views. So what's the solution? Oh, I'll get to that. The LVOT is not enough. Here's my favorite view looking here on is normal. You get four chamber, then you get the left ventricular outflow tract, include the aortic valve here in normal. If you look here on the right, this is a case of transposition, looks very normal, right? So that's not good enough. And what about crossing? If you can get crossing, is that good enough? No, it's not, because here's a bad angle, a case of transition with a bad angle, and it makes it look like it's bad angle because you're parallel. You can still see it looks like they're crossing. And here on the right, it's a good angle, meaning perpendicular to the septum, and it still looks like they're crossing. So crossing is not enough. I mean, ruling out crossing, if great arteries cross in some way, it doesn't necessarily mean that you've ruled out transposition. So honestly, I think the best way to rule it out is the sweep. And I try not to add extra burden to people who are already struggling, trying to get all the right views with good image quality and the right angle. But transposition can be tough, and really the best way to pick it up is just to do a quick sweep across the left ventricular outflow tract and right ventricular. If you look here on the left, it's a sweep from the four chamber to the three vessel view, and you can follow the aorta up and then down. The aorta goes up and down, and the right ventricular outflow tract goes across and it forms the V. Now here on the right, this is a case of transposition. If you just look at the very beginning, or even you look at the very end, in this case, the three vessel view looks pretty normal. Even though technically, usually the three vessel view won't be quite normal. It can be normal if you don't have the right angle. Here I'm showing it look relatively normal like a V. And the four chambers, the key is the sweep, everything in between. So as you're sweeping up, watch the LVOT. It doesn't cross, it just goes, and then it goes straight posteriorly and bifurcates. That's the difference. So this sweep, particularly if you've optimized the angle in the image, the sweep from the four chamber to the three vessel view is all you'll really need to pick up transposition. As I mentioned before here on normal, the LVOT and the aortic cross And you can see how it goes up all the way if you follow the whole sweep. Here on the right, you could see that what comes off the left ventricle, which is a PA, it actually bifurcates. So this is a case that was sent by one of our junior MFMs. She's not so junior anymore, it's a few years ago. But soon after for fellowship in maternal fetal medicine, she wasn't sure. She called me, Dr. Sklansky, I'm not sure about this. I said, please just send me a clip. She sent me this clip, and she picked up transposition, just going a sweep showing from the LV. It's just, if you go on up, you could see from the sweep, whereas if you just did stills or a clip of the LVOT and a clip of the RVOT, it might be hard to pick up. The sweep can be really key for picking up transposition. Now, transposition, L transposition, it's 1/10 as common as D transposition. And those terms L and D transposition are a little confusing. Here I'll explain. Again, transposition is always aorta off the RV, P off the LV. But L transposition, the LA connects to the RV. And the RA connects to the LV. So it's transposition with the atrioventricular alignment discordance. That's what L transposition refers to when we say, most of the time when we say L teaching. This is a case where the terminology is not the best. But that's the way we think about I think about LTG, or congenitally corrected transposition. This also is generally not associated with genetic abnormalities or extracardiac abnormalities, but it's typically associated with other cardiac abnormalities. Here's normal on the left, normal four-chamber, and this is normal four-chamber on the right. Now with detransposition, or transposition with the atrioventricular alignment concordance, I didn't even show you the four-chamber because it's normal. With LTGA, or transposition with atrioventricular alignment discordance, the ventricles are typically inverted, so the LV is typically anterior. So this is smooth-walled LV. You know it's an LV because it's smooth-walled, there's no moderator band, and it has a mitral valve. You know it's a mitral valve because it's more basal. The tricuspid valve is always more towards the apex, and you could see the tricuspid valve back here posteriorly. So on the right, this is a posterior RV that's hypoplastic, which is common with LTGA, a well-formed LV, which is anterior and rightward. This is just another example. Normals on the left, abnormal LTGA or ventricular inversions on the right. Often these cases have VSDs. This, you can see often there's tricuspid valve disease, Ebstein's, or other forms of tricuspid valve abnormalities. But you can see anterior is a smooth-walled, well-formed LV, and posterior and leftward is the RV. So with LTGA or transposition with atrioventricular alignment discordance, the four-chamber will be abnormal. The alpha tracts, of course, will be abnormal. If you look here, a normal, on the left, you can see the left ventricular alpha tract giving up the aorta, crossing over, and the RVOT giving up the pulmonary artery and the pulmonary valve. Here on the right is LTGA. You can see the smooth-walled LV anterior, and you could see the mitral, tempted to say mitral aortic continuity, but it's not aortic, it's actually a pulmonary valve. So it's mitral pulmonary continuity, but this inflow-outflow configuration where the inflow and the outflow are right next to each other off the same ventricle, that's a function of a left ventricle. So you know this is a left ventricle, it's anterior, and it's giving off the pulmonary valve, and here over here is the aortic valve. So the orientation, the appearance of this is a little bit different than the typical form of transposition, but if you try to go ahead and do your normal sweep, it's going to look very abnormal to you. So what's the diagnosis here? Let's see. Well, on the left, I think everyone can see this transposition with the pulmonary artery going posteriorly and bifurcating. How about on the right? This is also transposition because you could see that it's going posteriorly and bifurcating. But in addition, what else is going on? This is detransposition, transposition with atrioventricular alignment concordance with posterior malalignment of the coronal septum. We were talking about that when we talked about subaortic VSDs. We could see the VSD here, and we could see the crowding underneath the pulmonary valve. So this is actually causing subpulmonary stenosis with posterior deviation in the case of transposition. So finally, Last topic to discuss tonight is truncus arteriosus. Much less common than the other abnormalities, but very important to pick up. Truncus arteriosus, as you can see on the left, a single semilunar valve. There's not an aortic valve and pulmonary valve. There's a single valve. I don't like the terms hemitruncus and this and that. It needs to be a single semilunar valve giving off this coronary circulation, the pulmonary artery circulation, and the systemic circulation. Here we could see the aorta and the pulmonary arteries. Usually the aorta is the dominant, and then the pulmonary arteries are smaller. Sometimes the pulmonary arteries are the dominant, and the aorta is small and even interrupted. But here on the right, you could see, it's hard to get it all in one plane, but you can see the truncal valve, the aorta, and then the small pulmonary arteries coming off. It's important to measure the pulmonary arteries. Sometimes they're hypoplastic with truncus arteriosus. Here on the right, you could see the blue, it's blue flow coming off the truncus. It's blue because it's coming away. In the interest of time, I won't go over extensively, but sometimes it's confusing to distinguish tetralogy flow with pulmonary atresia from truncus, but one differentiating feature is that with truncus, you have flow away from the truncal root. With TET pulmonary atresia, it's towards. In this case, the blue is away. Here on the left, you could see the PA coming off. These are not good enough views to measure the pulmonary artery size, so you need to magnify more, try to get both pulmonary arteries, get the Z-scores for those, because those can be very important in terms of prognosis. This is another important aspect of truncus, is the truncal valve itself. A lot of times, some of the greatest morbidity and mortality related to truncus can be in those related to the truncal valve. Truncal valve is often very thick. On the left, you could see it's a little thick, not that bad, but you could have severe truncal valve stenosis in some cases. In some cases, you could, very common to have some truncal valve regurgitation. In some cases, you have both, truncal valve stenosis and truncal valve regurgitation. That was the case for this particular baby. This was at 33 weeks. You could see that there's stenosis at the level of the truncal valve. There's regurgitation and there's stenosis. You can see already there's some echogenicity already at 33 weeks within the ventricles. Here you could see still at 33 weeks echogenicity in the papillary apparatus. You can see there's some tricuspid regurgitation. But then at 36 weeks, things had progressed and the RV function and the LV function had gotten much worse. So this is a real risk factor for babies with truncus. Even if a truncus looks perfectly normal at, well, not normal, if the ventricular function is really good at 20 weeks. If you have significant truncal valve stenosis and regurgitation, these babies are at risk for evolving ventricular dysfunction, hydrops, fetal demise in utero. So why is that? Well, truncus is interesting. First, there's typically no ductus, unless there's an interrupted arch, but also both ventricles have to pump across the single truncal valve that's stenotic and regurgitant. So in terms of coronary flow, and the myocardial oxygen demand is high because it's a very high pressure, needs to generate a lot of pressure to get across the stenotic valve, so it increases the myocardial oxygen demand of the ventricles when you have stenosis. Like when you have a fetus with aortic stenosis, high oxygen demand. And in truncus arteriosus, if you have regurgitation, that will decrease the coronary supply, perfusion during diastole because of regurgitation. So increased demand, decreased supply puts these babies at risk for coronary insufficiency, myocardial ischemia, myocardial infarction, which is what happened to this baby, and this baby did not make it. So very dynamic, changing condition for babies with truncus with significant truncal valve disease. So it's important to evaluate that as part of your initial assessment to be able to prognosticate and to give accurate counseling. So we've covered a lot of ground, but I just want to leave you with some take-home points that most cases of critical congenital heart disease involve outflow tract abnormalities. The outflow tract abnormality is so important always to evaluate really very closely. Prenatal detection of congenital heart disease may improve outcomes, particularly for outflow tract abnormalities. Again, it's not just the diagnosis that matters, it's what you do with that information and the collaborative efforts that are taken and what you do in terms of where you deliver and so on. That makes a real difference for these babies. current rates of early detection remain quite poor, particularly for alpha tract lesions around most parts of the world, in fact, including here in California. Improved prenatal detection may be obtained within and can be obtained. And that's what we're doing here, trying to make improvements with improved training and education, which is what we're doing here, for those doing fetal cardiac screening. But translation of prenatal detection of congenital heart disease and alpha tract abnormalities into optimal outcomes requires collaboration between maternal fetal medicine, radiology, pediatric cardiology, surgery, nursing, and so on and so forth. So I know it's late for you guys, but thank you so much. Happy to answer any questions or join my colleagues with that.
Thank you, Dr. Mark. That was really wonderful. And we've got a few questions. If you could answer them, please. We'll start with Dr. Arvind. He says findings on 3VV in tetralogy of Fallot's, is abnormality in 3VV a rule or exception in TOF?
I'm sorry, what was the question?
Question?
Oh, it's the abnormality, I see. Yeah, is the abnormality of 3, with tetralogy, it should be, a 3-vessel view is very, if you can get a good quality 3-vessel view with tetralogy Fallot, it will often be abnormal. It won't always be abnormal, but you'll often see that the pulmonary artery will be small and maybe smaller than the aorta, which it shouldn't be. In the severe cases, you may have retrograde flow in the aorta. In the ductus, in the pulmonary artery. But one thing to be careful of, some people recommend the 3-vessel view instead of looking at the outflow tracts. That's a bad idea for lots of reasons. So it should be used in combination with outflow tract, left ventricular outflow tract, right ventricular outflow, looking at the aortic valve, looking at the pulmonary valve. But also the 3-vessel view can be very useful. And with tetralogy Fallot, I would say more commonly than not, there will be abnormalities in the 3-vessel view.
There's another question from Dr. Seema, how to differentiate CAT and PAVSD?
Right, I did allude to that. There's whole papers written about this topic. The fact is there's a lot of similarities. So sometimes that's important. They both are can be associated with DeGeorge syndrome or other syndromes. And they both are significant major disease that will require typically, multiple surgical interventions, transcatheter interventions. Tetralogy, pulmonary atresia VSD, also known as TET pulmonary atresia. The flow will be away from the aorta. For PAVSD, as you put it, the flow will be towards the aorta but with truncus arteriosus away from the aorta. With truncus arteriosus, the aortic valve, it's not really aortic, it's a truncal valve, is thick and often regurgitant. That's not the case with TET pulmonary atresia. Usually the aortic valve is well formed and not leaking. There's some other differences as well.
We have a patient the doctor has discussed actually over here. This is Dr. Bala Ganesh, who, if you can see the questions, she had a twin pregnancy and one of the twins had a large conoventricular defect without aortic override and prominent conal septum. She thought it's a pink tetralogy, but postnatal scan was normal and she found that the thin right coronary cusp was mimicking like a large conoventricular VSD. So could you comment on this, where we can get stuck sometimes where we think that's pink TOF, but it could turn out to be normal? Has this happened ever?
Yes, and I was going to keep that as a secret. I'm going to be showing you a case just like that later on. A real case that was called tetralogy, and it turned out to be normal. You might think, how is that possible? But your case is an example. In my case, another example that it's very possible. But again, I think the key is optimizing the image quality, the angle, because it's so, even though you might think it's easy, you know that it's not so easy, and it can, you can overcall it. Especially a twin pregnancy, the imaging might not be so, may not be ideal. It's going to be tough. In your case, you thought it was a VSD without override, and so I guess the mistake was that there was a VSD. Thinking there was a VSD when in fact there was not a VSD, unless you think the VSD closed. But if you think it was a large VSD, probably it was a false positive VSD in which case it's most likely because the image, you were not at the right angle of acquisition, you just didn't have the right image quality, which something you do the best you can, and this happens to all of us. It's just a limitation of scanning and ultrasound. We just try to limit the possibility of overcalling or undercalling by optimizing as best as we can the image quality and the angle.
Dr. Balu, so you would like
just
to add
once,
something?
it was a twin pregnancy. I mean, we don't know the follow-up scan. Maybe we look at it in a better if the pregnancy is, at 20 weeks scanning. And again, if you scan maybe at 24, 26 weeks, things would be better, clearer sometimes.
Yeah, and this one they mentioned postnatally it was normal.
Oh, sorry, it was normal.
That's a good point, though. I mean, when we always need to follow up these babies where we think there may be a problem, if we're not sure, the image quality is not good, the key is always to follow them up, and maybe the next time you'll have much better imaging.
All right, I don't think we have any more questions. Perhaps we could call it a night, I think. Dr. Balu, would you like to say something?
Yes, I think, Sanjeev, thank you. I think there was a wonderful participation despite the fact that we almost reached about 11:30. I mean, I could see that when Mark was almost completing, there were 400 plus people still logged in, which is not bad at all. And a lot of questions were asked, and I went through the chat box. I think by and large, we covered most of it. There are some questions, some basic questions and some other questions, which we can probably take up and discuss tomorrow. So I think great effort from the delegates to have stayed back and attended. I got feedback directly from my own fellows. Everybody enjoyed all the lectures and it was very informative. And so I think we can probably call it a night, as you said, and call it a day for Mark. And Mark, I strongly recommend that you get some sleep today.
Yes.
Tomorrow, as I already indicated in the group, if there is any sort of a delay creeping in, then we will sort of slightly reschedule Mark's talks so that he will finish clearly by around, at least by 11:30 p.m. his time. And we can always cover the rest of the talks and finish off the sessions. So we look forward to a very active deliberations and discussions and participation tomorrow. And thank you so much, Mark and Dr. Alpana. Wonderful to be with you. And Sanjeev, well done today. And congrats to your team.
Yeah. Thank you, everyone. We meet tomorrow, 8 a.m. sharp. Okay.
Yes.
Good night and take care. And goodbye, Mark from India. Right.
Thank
Bye-bye.
you. Bye-bye.
Bye.